Good morning, honourable members. Good morning to
Morning, Chairperson.
Minister Mbombo. Good morning to the departmental representatives. Good morning to our guests as well as to members online. It is Friday, the 12th of August at 9 o'clock, and this is the Standing Committee for Health. I wish to welcome all present, also those online. I will now ask all members to kindly introduce themselves. My name is Wendy Kaiser-Philander and I'm chairing the Standing Committee.
Good morning, everyone. My name is Member Christopher Fry, and I'm a member of this committee.
Thank you, Member Fry, and welcome to the Standing Committee as well. Members online? Member Bakufos, I see you online. Can you hear us?
Good morning. I'm Member Vensvoegel.
Morning,
Yes.
Member.
Loud and clear, Chair.
Thank
I'm
you
with
very-
Member Vensvoegel.
Thank you very much. I recognize yourself and Member Vensvoegel online. Member Vensvoegel also indicated that she will join us
Yes.
in chambers
Thanks, my love.
in a few minutes. Thank you very much, Member Bakufos. Please
Yes,
mute
my
yourself.
love. We are in. Thank you very much.
Thank you, Member. Can you please mute yourself? I will now allow for the Minister and the department to introduce themselves, please.
Morning, Noma Mbombo, Political Head for Health. Dr. Sadiq Karim, a DDG COO, is here and will introduce if there are any others online. But I'm just sending apology from Dr. Keith Kloete. Thanks.
Thank you very much, Minister.
Thank you, Honourable Chair. I'm Sadiq Karim, the Chief of Operations, and next to me is Ms. Champion, who's Director of Communications. I'm just going to see who's online from our department. Now I can't see so well. No, I can't see people from the department online. Warren Caesar, I see Warren Caesar's online. Our Warren Caesar, yes, Mr. Caesar is online. And I think that's all, Honourable Chair. We've just got one person from a department online. Is there someone in the chair? Oh, yes, okay. They'll introduce themselves. Thank you. Thank you, Chair.
Thank you very much, Doctor. Officials at the back.
Hi, good morning. I'm Halima Isaacs. I'm from the Manenberg Health Heideveld cluster.
Good morning, Chair. I'm Henry Bothman. I'm the Health Committee of Mitchells Plain, CHC, Deputy Chairperson.
Good morning.
Good morning, Amanda Hansen from Mitchells Plain Community Health Centre, Department of Health.
Thank you. Good morning.
Good morning, Damaris Kiewicz from the Cape Metro.
Good morning to you as well, Ms. Kiewicz. A warm welcome to you this morning.
Good morning, Akona Stemele from Health Ministry. Thank you.
Thank you very much. Honourable members, we will now immediately proceed. The department will brief us on the name change of the department as well as on the integration of the City of Cape Town facilities into the Department of Health. Members, please note that the department requested to present first, or rather Dr. Karim has requested to present first and will be excused from the meeting after his presentation due to other commitments. So members will then immediately after the presentation have the opportunity to kindly pose their questions as they did receive the presentation in good time, and I'm sure did make notes pertaining to their relevant questions. Without further ado, Dr. Karim. Or can I perhaps just ask, Minister, do you have any introductory remarks that you would like to make?
Can I just clarify for now what we're doing on the name change? Do we divide the times between the two, the name change and the City of Cape Town, so that we can be able to know that we don't put one side, I mean, time only for one aspect and not
Yes.
do we divide it?
With which part will Dr. Karim be dealing?
Honorable Chair, Minister, we can go. I've changed my meeting, so I'm at your disposal. So you can choose, Minister.
Okay. So are you happy that we start with a name change?
Perfectly happy with that.
Okay. So do we have any, for the duration, do we do half-half?
Yes, Minister.
Because it can take even long to discuss.
I think on the name change will be the shorter part of the meeting. So let us convey maximum an hour for that. If we finish sooner, we can do so.
Okay, all right, okay. These things. Thank you, Chair, and the committee about for inviting us, and also just want to acknowledge the community representatives that are here. Dr. Karim, specifically the Director for Comms, will take us through in terms of the presentation, just for a preamble, because it's not about that one just wake up and then change the name of the department. And for us, it has got to do, it's not conceptually, but also philosophical in regard to want to have that core part of what we want to drive to be there on the face. Firstly, with the World Health Organization definition of health, where it talks about health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. It just talks to the issue of the wellness. What does it mean? Just to make an example of when I explain it to the anti-SARS in terms of that, I always say that if you take a car and make it as health, and then you take the body of the car as physical health. You take the engine of the car as mental health. And then you take like the tires as the social health. How the health system has always been socialized to, it's about fixing the body of the car. You get ill, you go to the hospital, and then like a panel beater, that's what we have been doing. And yet we forget that there is also the other part, the body, the mind, the spirit, or the social, and also the mental aspect of it. And then secondly, how the health system has been socialized to, it's about everyone goes to be fixed, like a mechanic goes to be fixed, but we have never created an environment where people need to understand that there is a requirement for the maintenance, just like the car. So when we add wellness, it's about you consider all these three aspects as according to World Health Organization. But at the same time, you don't wait until the body has been knocked, has got all the bruises, and also you don't wait until the mind or the mental health has been affected. But there must be something that is happening outside the health system, because we end up being Department of Illness anyway, because people, when they are ill, they go there and then we panel beat them. So what we are saying is wellness, that you might not necessarily be having an illness, but your health matters and your wellness matters specifically. It means maintaining all these three aspects. Or you might have an illness like a diabetes, which is not going to go away. Or even maybe you're schizophrenic, psychosis is not going to go away. But it doesn't need to be you are at the health system or the health facilities in order to maintain yourself. You still have to make sure that your tires, you don't wait for until that they have got a tire puncture. You need to just to check that your lines, your whatever of the tires, they are still there, so that you don't wait until it's tire burst. Your body, you still have to go and wash the car and get it clean. Don't wait until it has been knocked over and then go and fix the health system. Similar with the engine, you still have to go and put water and put whatever oil in the engine so that you don't wait until the engine is up to the level that it needs to go to be fixed. So the wellness is about, it encompasses all other aspects, irrespective whether you are ill or not. And then lastly, Chair, I get reminded, because Member Barnes is here. She mentioned yesterday about how there have been so many patients that were at the mental health ward. Now, with the wellness, it says now that instead of fixations that are happening, that how many people in the hospital and how the hospital is not having beds, we need now to come with a conversation that so many people with mental health in hospital, what is happening? Because remember, those people didn't go to the hospital and then they got their mental illness there. They had all of these outside the health system. Now they are there to be fixed, yet something's supposed to be happening outside the health system. Are there any social ills? Is there unemployment? Is there substance abuse? What is it that we as a community, as every individual, can be able to assist, which is part of the wellness, so that we don't have a whole lot of the people going there? So it's also, lastly, it's about whole of society, that we are co-carers. Co-carers in the sense that if it so happens that mommy has been diagnosed of the cancer of whatever and now is for terminal illness, we should be able to understand that how can the health system facility can be able to empower the communities so that they could be able to be part of the palliative care, especially the social support. Remember, the body, the mind, and the spirit, or mental health, physical health, social health, it doesn't have to be there, that it should be there. How can we be co-carers as the family members, as the communities going towards that? So physical health is the part of the WOW, Western Cape on Wellness, is part of the physical health. That's what we've been doing, and everything else. Now to Dr. Karim. Take it off. Thank you.
Thank you very much, Minister. Dr. Karim.
Thank you, Honourable Chair, Minister. So I'm just by way of opening remarks. Ms. Champion is going to take us through the sort of the journey that the department has walked, and ministers explain now that it's not something that's just happened overnight. We've been on this journey for a long time. Ministers walked a long road with us on this journey. So the name change is quite reflective of where the department and the part of the emphasis that the department's placed on wellness. And part of that, as Minister explained, it's not just the physical wellness, it's also the psychosocial, the emotional wellness, as well as the physical wellness. And obviously through that, large part of it are upstream factors over which we as health department have little control over, but have a direct impact on people's health and mental well-being and physical well-being and psychosocial well-being. So obviously part of what we're trying to do is to emphasize that aspect of preventative care as well, so that we actually try to, as Minister explained, avoid people having to come into to seeking health care. There's obviously different phases of prevention. We don't have to go into all of that detail. But essentially for us, the name change does signify the shift, the mind shift also that's required from just purely treatment aspects to also including preventative aspects and the wellness aspects. So I'm going to let Ms. Champion's going to do a slide presentation that will just take us along that journey, and so members can understand where and what the genesis of this journey has been to date. Thank you.
Thank you very much, Dr. Karim. The presentation, did we receive that one? No, not that one.
A screen share now.
Okay, sure. And you will send it to us afterwards. Members that just joined us, will you kindly introduce yourself for the record, please?
Good morning, Chair, and everyone. It's Member Xeko.
Morning, Member.
Good morning, Chair. Good morning, Department Minister Ayanda Barnes.
Good morning, members, and a warm welcome to you as well. Just for your information, we are currently being presented by the department on the name change. So we will spend maximum an hour on that topic, after which we will then move to the integration of the city services to the department. Thank you, Ms. Champion. You may proceed.
Thank you, Madam Chair, and thank you very much
to the Minister for the introduction. She explains it so well. I almost wonder if I can do better. So the name change of the department, I thought I'd just share a couple of slides to help us to just think through that we're all on the same page. And some of these slides, I have to acknowledge the HOD, it comes from his head of the department address, which he shared with us in March. And I think it just captures, there are some of the slides that just capture the journey very adequately. And it is a journey that is much bigger than the department, and many of the people in this room will recognize some of the steps in the journey that has really been a collective journey for the health system to bring us to today. So the first point that I'd really like to make this morning is that this journey really is not new. Minister has quoted the World Health Organization definition, but the journey has been captured in various steps in the department. You know, it is something which has been with us collectively for a long time as something that we want to move towards. And I'll share some of the steps in the journey. I'll let the slide run, and then we can look at the various points of the key waves of health reform that really happened in the health department since 1994, you know, that brought us up to the point where we are today. And it's very well captured in this slide. The first point of the journey, the first wave, was really the provincial health plan, where what changed there was really the focus on the PHC capacity, where the health department and the health system became aware of the fact that really the focus of what we are doing shouldn't be hospice-centric, but it should be centered around the primary healthcare platform. And also then, along with that, the institutionalization really of the nurse-driven service. So the CNP became the mainstay of the primary healthcare service. In wave 2, just shortly, the Healthcare 2010 and the Comprehensive Service Plan, which was accompanied by the promulgation of the Health Act of 2003, which the members will all be very familiar with, and then guaranteeing the basic access to health services. These were really the foundations of the health system that were laid since 1994. And then in wave 3, I think we really see the move towards wellness, where we're saying towards Healthcare 2030, which in fact is called the Road to Wellness. Healthcare 2030, where there is also the increasing recognition of the upstream determinants of health and the WOSA, the whole of society approach, which is really starting to take shape in the strategy and the thinking of the department. And then that big snake-like disruptor there at the end of the timeline signifies, of course, the COVID pandemic, which hit us in 2020 and really put a bit of a pause on many of the things that the health system was busy with at the time. But I'd just like to draw our attention to the fact that there were lots of things that were happening before COVID that were along these lines of thinking that the department was developing and working with. Even though we were disrupted by COVID, a lot of this was already going on with very good results, and they were, described in all our annual reports, APPs, a lot of time in the standing committee, I'm sure. So the Western Cape on Wellness was the one program where it really is still about addressing the upstream determinants. So through exercise, nutrition, establishing a healthy lifestyle, positive habits which were established in those clubs and various networks to drive better health outcomes was really how the department started to use community networks and to acknowledge the role of community networks and community partnerships towards people's health, towards realizing collectively, how people take responsibility for their health. So the Western Cape on Wellness was the first program. Another program along these lines was the first 1,000 days, which was really a provincial intersectoral project where we worked with partners in other government departments, NGOs, other organizations, and there was a lot of work done in the services around this, where it was really an intersectoral project using a life pause approach on the premise that if you intervene in the first 1,000 days of a child's life, in other words, from conception to 2 years, by supporting the mother and the broader psychosocial environment within the child of the child, that one would actually get better health outcomes. So that was another project which the department was involved in towards wellness. A third one was really the focus on community-orientated primary health care, where the PHC services and other services are really rendered within a geographic area, again mobilizing the partnerships, mobilizing the community leaders, involving people on a community basis. In other words, organizing the health service in the community towards primary health care, which can happen outside the health clinic or health facility, which is, I think, an important step towards wellness, because wellness is essentially something, like Minister explained, that happened when you're not sick. So it doesn't happen when you're already at the health facility. And then the water learning sites, where they used multiple intersectoral and multi-level networks and partnerships to improve health outcomes in a geographic area, really tackling social ills and many issues surrounding, again, the upstream determinants of health, like in Saldanha, for instance, where there's an active involvement with the municipality, law enforcement, education, just all sectors and all levels really pulling together. So these were all examples of pre-COVID steps towards a more holistic wellness. So if we're looking at how do we go from here, so how do we get from the disruption of the COVID pandemic, and how does the department actually see this going forward? Again, there's a timeline, and I'll get to our strategy in the next slide. So when we take what the COVID pandemic has really given us, and it has taken from us, but it has given us something as well. It has given us an opportunity of unprecedented focus, in the sense that we can take the lessons from the last 2 years and we can look ahead and say, look, there's always going to be something like COVID. There might be other pandemics, there might be other crises, but how do we reorganize the health system now so that we can look forward towards resurgence over the next 2 years? Because we have to balance, we have to live with COVID, but we have to balance it with other healthcare priorities. Then also to balance it with a recovery outlook for the next 5 years, where we not only catch up from the pandemic, but we also reform our health system across all domains so that we can get better service delivery, better governance, better public health policy. And then further than that, even further, we've got to look far. We need this reset outlook over the next 10 years where we can ultimately move towards universal health coverage. Wellness is very much a part of universal health coverage. It is spoken of extensively. So that really is about our 2030 outlook. How do we actually do what we're doing now to bring us closer to that 2030 outlook? So it is a journey. So that brings me to our strategy. The department has adopted an internal strategy called Reset. It's a reset strategy, and it actually says health is everybody's business. And it's quite a radical strategy if you think about that, because it really explicates how health is for all of us, and it's for every person, and every individual, every organization has a role in health. And the strategy basically says that there's a clear need to continue to build a health system that is agile in its response to emergent needs. There's always going to be something, there's always going to be needs. It must be able to innovate and learn. It must be able to mobilize a broad range of stakeholders. I think that's one of the key learnings from COVID, is how important our other stakeholders are outside the health department to act in the best interest of the health and well-being of the people. So there you see the wellness clearly articulated. To govern for health. Now, the govern for health is it's a governance direction shift for the health department in the sense that we are acknowledging that there's a stewardship role for the whole of society, including ourselves. We must make the right choices. We must also do it well. So below, I've written, or there's a screenshot there that says, as we recover from the COVID pandemic, the Western Cape government as a whole is committed, and the health department, health and wellness specifically, to taking a whole of society approach to jobs, safety and well-being, with the express purpose of upholding the dignity of each individual, household and community in the Western Cape. The pandemic has, with devastating effect, exposed the inherent link between health and the social economic drivers of sustainable development. So, there's like a renewed recognition of how important it is. So I'd just like to share with you also our infographic that we really love inside the department. It recognizes also these 3 spheres of the reset agenda, the things we must do, the things we must be. It speaks a little bit about our hearts and our culture and the governance in the department, so that we can aspire collectively towards a healthy society, towards a trusted health system, towards a people-centric health system, towards an equitable health system. So that equity is also coming through very well in the reset agenda of the department. So we aspire to become a health system that is people-centric, trusted and equitable. Yes, we must provide the right care at the right time, in the right place, and care that puts people first. We are now nailing our colors to the mast there. We're saying that's the kind of care we would like to do. We've always done that. It's just now being explicitly articulated in this strategy. And then a system built on caring and competent and empowered workforce, clean governance, a clean audit, that kind of thing, innovative and accessible service delivery, and a health system for you. It requires us as a department, the broader provincial government and society as a whole, to more systematically address the social determinants of health, making the paradigm shift to health is everybody's business. By changing our name to include wellness, our intention is more explicit, and we ask you, everybody, to embrace this with us, with renewed commitment of not only health, but also the well-being of society. So the health system, there's a couple of things that we're doing internally. There's a health system delivery reform, which basically says health does not stop at the boundaries of the health system that we are used to, but we are also trying to address the social determinants and influencing them where we are able to. We are reforming our governance. We're making this paradigm shift from a disproportionate alliance on command that's internally and control. We are honest. We know health people and the health system can sometimes be quite hierarchical. We're working on that to be more inclusive, more participatory, and to build consensus in our leadership style, both within and without. There's been a couple of stakeholder engagement already, renewed efforts to actually bring different voices into the governance area of health. And then health policy reform, which aligns with the aspirations for a healthy society and calls for a whole of government, whole of society approach, a social compact, really, to build the resilience and to create the health system we all want and that our people deserve. And of course, UHC reform is part of that. So to the name change, how does the name change? Well, the name change, Minister Bombo challenged that. She said, guys, it's time now. We've been talking about this, been saying these things, we've had these reforms. It's time now to put it into action. So there is a recognition of the historic wellness journey. Minister made an announcement of her intent to change the name of her provincial ministry to the Department of Health and Wellness, which happened late last year. And as we reset our transformation agenda in the department and reaffirm our commitment to the ideals of Healthcare 2030, it is an opportune time for the department to change its name to Department of Health and Wellness, to reflect that change. If we articulate it, it is reflected and we are going to be reminded, and I'm sure held to account for the wellness part. Healthcare 2030, the road to wellness, was obviously supported by Cabinet, Provincial Cabinet, and it defines wellness as not merely, like Minister said, not just the car that's broken, but also the maintenance to make sure that it runs smoothly. So this is something that we must all work towards. So the intent is welcomed by the department. It's very much aligned to our Health is Everybody's Business strategy. And just in terms of the official process, there is an official process. So the official name change involves a legislative request to the presidency to publish an amendment to Schedule 2 of the Public Service Act. So this is being undertaken by the Department of the Premier. And once the official approval is granted, then we will roll it out fully. But in the meantime, we remain committed and excited on this journey to wellness. Thank you very much.
Thank you very much for that insightful presentation, Ms. Champion, and taking us through the journey in relation to the name change. Can I perhaps just ask a question? Let me first ask, are there other members that wish to pose a question? I don't think we have any members online anymore or are in chambers. I see member Tego, Barnes, only 2 members. Okay. I'll go first, member.
Okay.
And then I will grant you an opportunity. My question just pertains to in terms of wellness. You spoke about social determinants and other factors that influence health. What is the department's, what are your plans to collaborate to get that holistic approach with other departments to sort of relieve pressure, but yes, also to see to the wellness side that will ultimately impact on health within society at large. Member Tego, and then Member Barnes.
Thanks, Chair. And let's welcome the presentation, which is very much detailed and informative. I just wanted to understand on the issue of the background. I've noted that the background starts from 1994. But if we would take that, for us to understand the situation we're in, we've got to, because our life didn't start in 1994. And the challenges that face the department didn't start in 1994. So to redress and address challenges prior to 1994, because you have got to have an understanding that how was the health system to prior 1994 and what are you trying to redress and where are we going? So if we can get clarity as far as that is concerned, so that we don't become harsh on you on challenges that have been there for centuries. If you can just draw us a picture of what has happened or what is happening. And then on the issue of the involvement of stakeholders, which is a very good thing, such as municipalities and sister departments. Mine is to check the level of collaboration and cooperation from them, because we have seen since the COVID pandemic, whereby you would find that the health system was being put under pressure by other departments, such as the economic opportunities, where we would have a serious problem with the sale of alcohol. And then whilst on the other hand, the other department is seeing that as a way of economic development. And that, so the collaboration between departments and how possibly can they lead us to a positive direction. And then I think the issue of addressing the social aspect, the chair has touched on it. And then you touched on the issue of inclusivity and participation. You know, because sometimes when we do oversight on, we would find that in different clinics, when we question issues of clinic committees, you would find that there is no clue from the people, the community there, or the clinic management itself, which is, when there is that collaboration between the community and they become part and parcel of the system and advise where is you and some of the operations, then they are able to necessarily advise how to address issues there. So how is that? That process in terms of inclusivity currently, and then how are you planning now with the new name that to involve other stakeholders in ensuring that, and then there is this, I think the other one will touch on it when we come to the presentation itself, the issue of the City of Cape Town and the department taking some of the roles and responsibility.
Sure. Thank you, Member Barnes.
Thank you, Chairperson. Chairperson, Member Tlago actually makes mention of my ideal question I wanted to ask on the collaboration of other departments and stakeholders. What is their role and how are they involved and how far are they? So I think I'm partly covered by Member Clever. And then there's one slide that was presented on the reset of the agenda. One would want to welcome that because it stipulates on innovative ideas and motivation. One would welcome. I think Minister made mention now on a question I asked earlier about the psychiatric hospital yesterday. When she responded, she spoke of wellness. I think this presentation is responding to the wellness part, but I would also take the opportunity to say to the minister, maybe we should call in the minister on the part of saying the beds, because the reality is there were 19 people that we found there as a standing committee on the ground. How do we address that? That was my question. But the wellness, I'm not running away. There is a problem and it relates to that. So I wanted to respond to that as well. Thank you, Chair.
Thank you very much, Member Barnes. Member Van Vogel, you have a question?
Thank you, Chairperson. Chairperson, mine is, I think I'm partly covered or mostly covered by the previous speakers. But for me, first, it becomes a problem if you only receive a presentation a day of the meeting. So we really need to look at that we receive the presentation beforehand. Then the one issue, I just want to check from the department side, if 2020 were a disruption, have we addressed staff wellness for a change in the department? Thank you, Chair.
Thank you very much, Member Van Vogel. Duly noted, Minister.
Thank you, Chair. I'm just looking at it. Okay, still on time. Dr. Karim will add some of the, the responses in regard to the social determinants of health and also the collaboration. Indeed, that it's a whole. Health is everybody's business. It is the whole of society, and also that's why when we want to look at the universal health coverage and also the NHI when it's also implemented at the national level. We always, Western Cape, saying that for us is UHC plus, because the current universal health coverage models that are there, they don't take into consideration the social determinants of health. And also, when we speak about now, specifically for the wellness part of it, this document, the Healthcare 2030, I'm not sure whether we have just to show, if you don't have it with you now. Okay. Healthcare 2030, I think specifically page 15, Healthcare 2030, the road to wellness. It does speak about the background that when that document was eventually produced and published in 2014, it underwent a whole of the engagements with all the stakeholders throughout the province. So it is a result of the document that was not made somewhere in a boardroom. Everyone had an input across all stakeholders. And then in terms of the implementation, if you look at our strategic plans, because it's 2030, but we took chunks 555. So we are in the fourth. 2014, we're in the second, 2019. Then we are working on the 2020, 2025 now, which is part of this. Hence now the part is about the name change. But but it's a journey that has happened throughout. So from at the conceptual level, there have been stakeholders throughout. At the implementation level, in terms of the various small chunks, it's also part of the consultation. And then by the time we are in the 2030, we will have done all of those consultation in regard to that aspect. Now, in regard to the 1994, the democracy in South Africa, that's when it started to have the health reforms. It's an official first health reform after the democracy, which is where now, if you recall, before that, we were having the health system. I remember then, because I was still an academic, not an academic then, like in the Western Cape, where we'll find that then at the budget of the two hospitals, Tygerberg and Grooteskiel, used to be equal. Actually, Grooteskiel alone used to be equal to the budget of the health services in the Eastern Cape for the whole health services. So the first reform of realignment of the health services in the province, it happened. And then by the time there was the Health Act 2003, in regard where the national say that its responsibility is only on the policies, norms, and standards, but they won't be owning any hospitals or staff, and all is part of the health reform. Specifically in the Western Cape, the second health reform after 1984, it was Comprehensive Health Plan 2010. Where we are saying now we are shifting where we have to do the balance of primary health care, which was left behind in the old apartheid Western Cape at the time, where the focus was more hospice-centric. So we have to focus on the primary health care and also the support that's supposed to come from the hospital to the primary health care services. Healthcare 2030 is the third official health reform in the Western Cape. It's the official third one, which is now what we are saying that as we implement it, there's been now some new other reforms that are being proposed. In our case, the universal health coverage, which is you won't be able to do it if you don't make sure that part of the wellness to tackle the social determinants of health. That's why we are at it. Because even if it's an NHI approach, you still have to have wellness, because they're consuming actually the health system where it has been more of the hospice-centric hospital base, which actually it comes with a whole lot of resources, but it doesn't help Auntie Sarah, because Auntie Sarah might not necessarily need a heart transplant, is ill now with the issues of poverty, is going to bed hungry with no food. And for the first time now, actually, we even see malnutrition, not only to the children, I'm talking about where even they are the producers of food. So when they go to the clinic, we'll just say, oh, you are underweight, you are malnourished, but you won't be able to give them food. So that's why we are telling them there, whether in the farming communities or whoever, or even Department of Economy or Department of Social Development, we've got poverty in this area. Cannot have poverty in Botrefield, cannot have poverty in the Marikana, in Overstrand and something like that, yet these people are the food producers. Therefore, do something. So we're trying to not to focus more on mopping the floor. Where are the beds so that these children can sleep? But there is no clinical diagnosis besides malnutrition. So we work with them in that space. Now, what we are doing now as a government is that we are even part of these priority that are under the Premier with all the departments involved. For example, the dignity and well-being, which is co-chaired at the HOD level, the DSD, the Department of Health, the Department of Agriculture. All those issues are being taken care of that. Because for us, we have to always remind them, give them statistics. There is poverty, there is violence, there is whatever. Safety, which is now, is also a part of it. We also co-chaired. The mere fact that now Violence Prevention Unit is being now driven from our side, although it's for the whole of the province. We participate in the jobs. Jobs is an economic cluster, but we are part of that. So when we say to them, okay, we're all going to be able to provide you a land or space that we own in regard to, let's say, BioVac for the vaccines or for other treatments or whatever. But in exchange that
there should be job creation, because when you are healthy people, healthy profits. If all people are ill, it means that you won't even have, those people will be taking time off and they won't even do the production. So we're doing for those, but for them, for us, in addition, we say, show us, map it in the hotspots. For example, for us, if there's a COVID or if there is a violence, we'll say that it is in Kailicha, in Harare. We want now to show us where are these jobs we've created. It's not enough to say 20,000 jobs. Plot it. In GRD, where exactly? In Vescas, where exactly? In Central Karoo, so that when we do the triangulation of the data, we say, oh, there's been improvement in malnutrition in this case. There's improvement in the violence cases that are coming to us. Improvement in the mental health, probably because there's been improvement in the number of girls going to school, or there's improvement in pregnancy, number of girls going to school. There's also improvement because there's been high level of employment in this area. That's how we are able to do all of those things. Of course, indeed, when it comes to the staff, I did mention that the occupational health safety, which now not only happens there at that higher level, it also goes at the branch. It means that at the local level, where we bring services to the people, where staff that they not necessary. In addition to that, they have to come part of the wellness in the .P, but also within our facilities where people can just come and also come for the counseling. Thank you, Dr. Karim.
Thank you, Minister, Honourable Chair and members. Maybe just a couple of points to add. Challenges prior to 94 were significant, as you all well know. I mean, we had a extremely, as Minister mentioned, extremely fragmented health service across different departments. And obviously all of that had to be integrated into a single Department of Health nationally and then therefore also provincially. But I think one of the focus areas also prior to 94, which is an extremely hospice-centric service, and part of our challenge, and as Ms. Champion explained, part of our transformation journey, I guess, has been to try and transform from a hospice-centric health service to a stronger focus on the preventive aspects of it, and hence the wellness linked to wellness. Obviously, and part of the health is everybody's business. If we look at the governance reform, that's been part of a long journey since 1994. Of trying to make sure that essentially we have all the services under one component in the health. And in fact, the City of Cape Town conversation clinics that we're about to have is part of that journey of trying to bring everything together under one system in terms of health reform. There was also a question about and I did mention in my opening remarks about the upstream factors, and alcohol is in fact one of those upstream factors, and we've been talking for a long time, particularly during COVID. Working very collaboratively with our colleagues across in economic affairs. We've been working also, as Minister mentioned, in terms of through .P, through the Department of the Premier. We are establishing a now violence prevention unit in the Department of Health and Wellness. And that will have a focus on, in the department itself, using a preventive model called a Cardiff model, where in fact we're also trying to focus on trying to identify the violence hotspots and trying to address strategies in those hotspots to address violence in various communities. And there's a whole process around that. There's also an alcohol harms reduction draft policy, and across obviously working with all the departments in government about in reducing the harms that alcohol obviously produces. And that's obviously starting to show some benefits already. Just in terms of the staff wellness question, I mean, very specifically, and during COVID, that was one of the key aspects of the Western Cape approach on COVID was in fact to make sure that our staff wellness, that we had a very strong focus on staff wellness, and everything from physical wellness to emotional wellness to support groups to online support. We also obviously have a support to staff on site as well. So if there is something that happens immediately, we're able to support our staff. Everything from that to making sure that staff are working in a safe physical environment where they feel safe and where they obviously feel valued and cared for. We have also a number of policies that we've been introducing to ensure that the staff wellness is really staff taken care of. So there has, and obviously it includes additional staff, it includes bringing in contact staff, etc., etc. So we've had quite a strong focus in the department on staff wellness, particularly during COVID. And obviously post-COVID is one of the key lessons that we've learned during COVID, that obviously we need to have a stronger focus on staff wellness. So we've really been putting a lot of emphasis on staff wellness. I think Ms. Champion just wants to add to some of the other aspects. The collaboration, yes.
Thank you.
Thanks, Dr. Karim. Yes, in terms of the collaboration, I think I recognize some faces that were at our departmental external Indaba, which we had earlier this year. I think it was in May. We are planning to have a follow-up. What I'm saying is that there is really a move internally in terms of the governance journey to bring in the voices. I referred to that. I referred to that in my talk. But there is also a clear commitment of the senior management to make that part of how we do things. And the Indabas is one aspect. There's also a provincial steercom, which is chaired by our HOD, where all the departments come, but not only the departments. There's also civil society that participates, and there's also a stream for a community stream, which is headed up at this stage by Mr. James Kruger. And the purpose of that vaccine steer, it used to be a vaccine steercom. I think the decision was now taken to broaden it, because the people at that steercom felt that it gave benefit, because it gave them the opportunity to talk health is everybody's business, in action. And so there's that steercom, and there are various other forums which are existing informally and formally. I mean, there's some bodies and some statutory bodies, there's clinic committees, hospital boards, but there are also informal places where the districts and the facilities are interacting with their stakeholders in their area. So I think there are many attempts to bring in the collaboration and the voices, and at points where it's not only about the department saying this is the strategy and this is what we're going to do, but also bringing them in the planning phases and in the implementation phases, because we need one another. Health is everybody's business, and we need all hands, all people on deck and on board and with us. So I think that is what I wanted to say about the collaboration. Thank you very much.
Thank you very much, Ms. Champion. Minister?
I think the question of clinic committees, sorry, I forgot, because I got reminded now. From the political side, I've been driving the Nothing About Us Without Us campaign, going to district, sub-district, who are the stakeholders, the clinic committees, the hospital boards, and the councillors and the MPs, as according to our 2016 Facility Board, Health Committees and Facility Board Act. They are the key stakeholders. Indeed, when we started this term in 2019, we had plans of not leaving communities behind, and also wanted to see to it that the act we give into effect into that, and especially at the primary healthcare level in regard to the ideal clinic that talks about leadership with the communities as part of it. Unfortunately, with COVID, we had to pause on that, because at the time there was going to be some trainings that was going to happen with the clinic committees. Now, with the COVID, the first thing was about, because everyone we didn't know much about the COVID. It was about stay home. We're busy now sorting this. And therefore, even with the clinic committees and hospital boards, they didn't participate. They didn't know what was happening. It was just us telling people what to do. So with the lessons learned, as Marika has indicated at the Indaba, was about we leave no one behind. So that's why we started that with every clinic committees, combining them. Just making an example, if we're talking about the Khayelitsha substructure, it has got
about 10 clinics, and then with their clinic committees and the hospital board members, and then the councillors in that area, plus the member of parliament legislature are part of that. And then we'll talk about these three BNPOKI, where we have got the political society, civil society, and also the government. And then we bring the department to be able to present in terms of what is happening now post-COVID going forward on the service redesign. And also we bring the councillors, because at the end, health services are mostly, especially outside the rural areas, they are under the province. The mayors, even themselves, sometimes they don't even know what is happening because it's a provincial health services. That's what we bring in. Soledad, member Van Vogel was there and also indicated that she so wished that this would have happened before, because in some of what was presented by the district team, sub-district team, municipality team from us, it was something that the communities would have wanted to know. In as much as that would have wanted the whole public meeting, we can't, because we have to start with our own, which is the ones that we appointed as the statutory bodies. And then for them, because they are representing the voice of the community, they can go out. Just like the school, start with your SGB and tell them what are the plans about the school before you call the whole imbizo of the community. Thank you.
Thank you very much, Minister. Members, we agreed on an hour for this presentation for questions, and I really want to afford our Health Forum members present this morning to also pose their questions. Can I ask for you to please hold back on your follow-up? Thank you very much. And then there's someone in the gallery. I just want to determine, sir, are you attending the standing committee meeting? You are most welcome to join us downstairs. Yes. Thank you. Any one of our guests that wishes to pose a question on the name change? Ms. Kivitz, you may proceed. Thank you. Can I please ask to keep your question to the point? Thank you.
Definitely to the point. I think on the name change, as possibly as the department always look at us as those that has not been elected, what was the communication strategy on the department's decision on the name change? That's the one question. And then on the second question is on the 29th of April at Century City, the department had the Indaba. We few months down the line, and if we talk about wellness, and I hear the minister and an argument around wellness, but we see at our health facilities that there are hardly staff. So if there's hardly staff, what does that mean for patient intake? Because if wellness is the key to the name change, then we need to look at what happens at service delivery level. And at the moment, that is one of our biggest concerns as communities, because there are no staff to deliver the service. I mean, just the other day at one of the PHC facilities, there were hardly any staff. The manager came out and said, look, we only possibly will be able to take 20 people, but there were 140 people standing outside because there were no staff. So I think the department needs to really let us understand, if we talk wellness, how are we going to deliver a service in the absence of staff not being appointed?
Thank you very much, Ms. Kivitz. Sir, at the back that just joined us downstairs, would you kindly introduce yourself for the record, please? Thank you.
Good morning. My name is Kwezi Chacham. I'm from the Nyanga Clinic Committee, Nyanga Health Committee.
Thank you so much
Thank
for
you.
joining us this morning, sir. You're
you.
most welcome. Any other questions pertaining to the name change? from the guests, our Health Forum representatives? I don't see any. Minister, can I give over to you? Thank you.
Thanks, Ms.
Yes, Member Bakofos, we agreed from the onset that we are going to give an hour to this presentation. So within this hour, I just wanted to afford the opportunity to our community representatives to pose their questions as well. Depending on the response and time, I will get back to you and Member Van Vogel if the time
okay.
allows.
No problem.
Thank you.
Thank you, Ms. Kivitz. It's exactly the point that we're trying to make is that you cannot focus only on when the car is broken. And then you question about how come that there are so many cars parked in this panel beat. That's the point we're trying to make. We need to also to ask the question, in addition to why are there so many broken cars that are parked? How come that you don't have many mechanics to fix those cars? That's the question that we are asking. But what we're asking when we add wellness is about how come there are so many cars that are broken? What is it that makes these cars to be broken? So you have to reflect in terms of what is happening outside, because it's not about those cars were broken when they were in the panel beat. So it's the same thing. It's a relevant question that so many people who are ill, so many beds that are required, so many staff that are required. But now in wellness, at the question, why are so many people who are ill? Therefore, we are saying that let's not focus on the curative aspect only. Let's also look at the preventive and promotive so that we don't have a lot of traffic of people that are being ill. As we have indicated that the social factors are the other contributors on having the people who are ill. So we need to balance the equation, not only curative, but also and B, we are not saying that we are not taking responsibility in terms of people when they are ill, but it must start also elsewhere. I made an example that if you are diabetic, you will be on treatment probably for a long time, but you need to change the lifestyle. How do we ensure that the issue of the physical exercises, the issue of the healthy eating, and all of those are being taken care of? Because you can pump as many pills if the lifestyle doesn't change. It's similar issue. You can put as many mental health beds, you can put as many staff in terms of the beds, but what is it that you are doing, all of us as a community, to ensure that if the substance abuse and alcohol is a major contributor to the mental disorders, specifically to the young people, what are we doing in regard to that? If teenage pregnancy, we have so many deliveries of the bed of the teenagers who are there, what is it that needs to happen, whether it's at the school level, by the families, by the communities, to reduce the number of teenage pregnancies? In addition, that you'll be looking at what are we doing to ensure that teenagers are being delivered safely. But don't only focus on that. You need to be able to stop the tap without necessarily focusing much on only on the mopping the floor. So that's the point in terms of the name change of the wellness. Lastly, the issue about the name change. I think Marika has also mentioned that this is the third reform that talks about healthcare 2030, the road to wellness. That started long ago. Now it was about just what we have been doing as part of each and every 5-year strategic plan in terms of the giving effect to the healthcare 2030. It's part of it that we are doing. It's not about something that just happened. It's part of it. The engagements have been happening. But what the communities want to know is about, okay, when you say and wellness, what is it that you are doing from your side that talks about the issue of the wellness? That's when we showcase Western Cape on wellness, the integrated services that are happening, hospitals without walls,
because now it's not that people have to be taken care only in the health facilities. It could be if we have to bring services at the SASA service point, we bring the services there. So it's part of that. But at the same time, we also share that what it could be your responsibility in order to close the tap so that we don't keep on mopping the floor. Thank you very much.
Thank you very much for your response, Minister. And then I see your hand at the back, ma'am. You may proceed.
I just want to raise the issue of the wellness. It's all good and what we're talking about how we should go about educating our communities around wellness and their own health. But we as Manberg, Heideveld Manberg cluster, we have a challenge with getting venues because our acting facility manager have on several occasions approached the city of Cape Town for a venue. And that is one of the things that we should actually look at, where in the community we're going to have these wellness hubs, because a wellness hub is something that would make people life easier to go to a hospital instead of there's a lot of people that have challenges with wheelchairs and these walkers, and they can't get to the hospitals because taxis don't want to load them into the taxi. So that is one of the challenges that we have. And with the venues, getting venues as a hub, because the community centers that the city, that is owned by the city of Cape Town, have programs. So we need to look at how we can get those community centers up and running for our wellness, because the wellness hub cannot happen within the Heideveld Manberg area because of there is no facility other than private owned facilities within the community that has to be approached, but that is a cost involved. So that is the challenge that we have. Then the mental health issue. I hear the MEC is talking about youth that has mental challenges. But what are we looking at the parent or the grandmother or the great-grandmother bringing that mental health young person into the facility? Is there any support, which I know there isn't? Because if that parent goes into the EC emergency center, bringing in that patient, they are as stressed as that person, but there is no support. So if we can even look at that, how do we can get that service as well for the parent, the grandparent, and the great-grandparent, because that is missing between the person that is coming in for the treatment and the family members. So yeah, thank you.
Thank you, ma'am. Can we just have your name again, please?
Sorry, Halima.
Halima.
Isaacs. Yeah.
Ms. Isaacs, thank you so much for your input. And I think it's more about a request and recommendations accordingly. Minister, would you like to respond?
I'm sorry, Chair. I'll suggest, because this question is not necessarily specifically on the wellness, but yes. I think when we, I'll park it so that when we speak about the clinics and everything, and then we answer as part of that.
Makes sense. You fine with that, Ms. Isaacs?
And remind me if we don't respond to it.
Yeah. I'm sure she will, Minister. Thank you very much. Member Van Vogel, you're taking chances now?
Yeah, thank you so much, Chair. I will be first. Chair, from the department, I just want to check what are the powers and functions that will be added to the department as a result of the name change. Then secondly, will there be any changes to the organigram as a result of the name
The
change.
addition to.
Yeah, and lastly, I think you covered that my last question.
Thank
Thanks,
you,
Chair.
Member Van Vogel. And then can we agree any follow-ups that you might have on that questions you will put in writing or oral ask yes or yes? One question, Member Paku Bakufos.
Only one, Chair.
Only one member.
Okay. Thank you, Chair. Chair, I would like to know from the department, what are the costs associated with it, with this game change thing? And do you have a breakdown of cost expenditure and how far is the process has been concluded? That's my question. And it's only one.
Thank you so much, Member Bakufos, for the discipline portrayed. Thank you, Minister.
Thank you. Where I'm sitting now is about that I'm not aware of any kind of additional. It is all about the paradigm shift, doing things differently. For example, when I made an example that after the health indaba, in terms of the service redesign, things that now we have to do differently, specifically from the lessons learned through COVID. It's about where we talk about hospitals without walls. For example, for the first time, where I indicated that you bring these integrated services, even at the taxi rank, you bring them at the mall, because it's part of wellness where we take into consideration that services don't only have to happen inside the facility. Even the mere fact that it's lessons learned during COVID, we have to deliver these packs of medicines to the people, and also to do follow-up calls, especially to the older persons, instead of saying that, come back, auntie, unnecessarily, therefore you can just do the follow-up in regard to that aspect. And also now, like recently, I went to take Table View Senior Citizens Club, about 100 of them, where they were gathered in the hall. They're doing their own thing with the NGO that takes care of them. But for us, we took an opportunity through the Western Cape on Wellness, which is the health promoters, where they show them in terms of the exercise and all of those part of packages, which is previously, it wasn't something that we were doing. So it's part of the lessons learned. It's about the service redesign, but specifically it's about the right service, because you need to provide the right service at the right place, also in terms of the right people, and also at the right price. Again, making an example, it's about like now in Kailicha, when we open the eye clinic for the diabetics, which often that used to be part of the district hospital, at the higher hospital level, like Tigerberg, or even at the level 2 hospital. But when we realize that these people in the Kailicha becomes too much to go to the Tigerberg, diabetic people, therefore that service, although it's a high level for specialists, let's take it to that level. So it's about service redesign and also influence about, because it must be person-centered care. It's influence about what is happening, particularly in that area, instead of having one size fits all. It must be tailor-made as accordingly to each and every area, as influenced by the population and the behavior in those kind of areas. Dr. Karen?
Thanks, Minister. Maybe just to respond to the staff pressure question as well. That was asked. Obviously, as department, we've been facing significant pressures over a long period of time. Skivits would know that. And obviously, what we're looking at from our perspective in terms of the staffing during COVID, for example, we added an additional 1,000, just about 1,000 contract staff to our service, and we obviously kept that as well. In the province, we're lucky that our attrition rate is relatively low, much lower compared to other provinces at least, and we're able to retain our staff, and we're able to, in fact, fill our posts quite quickly. I think we've been to the standing committee before, and we looked at the filling of posts at the standing committee level as well. But part of the name change and part of, as Minister said, the paradigm shifting towards a stronger preventive focus would be, in fact, to hopefully reduce the pressure on our clinics and our hospitals by focusing more on preventive aspects. That would obviously include the psychosocial aspects as well as the physical aspects. We're also looking in certain areas, obviously, at expanding our services as appropriate. I mean, Minister, over the last week already has been to 3 openings and launches of additional services that we've opened in the department. The noon was the last one. Administer the midwife obstetric unit administer opened on Thursday. Today's Friday. Administer opened for us. Before that, we launched an additional service at Tygerberg Hospital, for example, which is a world-class pediatric neonatal service. You know about the robots that we've launched, etc. So from department side, within the budgets that allocated to us, we are, as far as possible, expanding our service footprint so that we are obviously able to provide better services to our communities. Thanks, Honourable Chair.
Thank you very much, Dr. Karim. Members, that concludes our question session on the name change. Is it in order? I just want to check in terms of your time, Minister, as well as officials, if we take a 15-minute break and come back for the second, or are you fine? Okay. Members, are you happy that we take a 15-minute tea break and come back at past? We
No
continue with
problem.
the second presentation.
But babe,
Yeah.
No additional staffing, specifically that we have to do the wellness. It's about just shifting things, doing things differently. Nothing.
Yeah. Thank you very much, Minister. Members, we will now suspend until 10:30. Tea will be in the members' lounge, and our guests, you're more than welcome. Thank you.
Chairperson, I just want to say that this morning when I came in, I left my jacket on the chair in the passage. And when I came back from the tea room, it was missing. I have reported the jacket to the reception downstairs. They said they will look into it.
Thank you, Ms. Isaacs. Ms. Jamke has also reported it to security services.
Okay, thanks.
So they are on the lookout for it.
Thank you.
Thank you. Thank you very much, members. We will now proceed with the second part of our meeting. Dr. Karim, are you presenting?
Yes, Chair.
You may proceed. Thank you.
Thank you. Slides up. Okay, there we go. So, Honourable Chair and members, I'm going to talk a bit, as we requested, on the integration of the City of Cape Town clinics into the Department of Health and Wellness. So let me start perhaps by giving some background. I thought it's just important to sketch the background so members can understand how the integration had happened and what some of the history behind this has been. So to start off with, both ourselves in terms of WCG Health and Wellness and the City of Cape Town acknowledge the roles and functions that are related to health services and municipal health services that are assigned in the National Health Act. So that's obviously just to give some of the understanding of the legislative background. The City of Cape Town currently, in fact, provide primary healthcare services in 105 facilities in the Cape Metropole. The shared services that we're talking about specifically are across 9 clinics, and those are the 9 clinics that I'll come back to that have been integrated with a 10th facility into the Department of Health and Wellness. But just to go back a little bit in terms of the Cabinet resolution, that resolution was taken on the 15th of May in 2015. And that Cabinet resolution stated that WCG Health maintains that personal primary healthcare services in the Cape Metro Health District should be rendered by a single authority, and that WCG Health is the only authority that can constitutionally assume that responsibility. And that was reaffirming the Cabinet decision that had previously been taken on the 26th of September 2012, as well as the IGC, the Intergovernmental Committee resolution that was taken on the 23rd of June 2014. So this actually has a very long history in terms of the integration of these clinics. But looking at some of the reasons for the handover of what we call the joint facility, so these are the 9 facilities plus the 10th one for Santa Cruz. So I'll refer to the 10 facilities. So the current joint service delivery model is obviously not ideal because there are duplicate services under the same roof. So literally in the same building, you'd have services provided by the Department of Health and Wellness, and you'd have services provided by the City of Cape Town. And this often happens in the same building, and the intention was obviously in the current financial climate, and just the current climate and just the conversation we had earlier also about the preventive aspects, we look to find opportunities to streamline those services that will obviously enable us to respond in a comprehensive manner, that would include both the preventive aspects as well as the sort of clinical service aspects, the clinical service provision aspects, which we traditionally would have been responsible for. But the handover of these 10 facilities then really is part of trying to improve efficiency in our services as we move towards a single accountable authority in the metro. And it's a milestone event in terms of being able, as the trajectory has shown, that we've been talking about this for a number of years. So there has in fact been quite a significant milestone event. But I think from a client perspective, it obviously would make a lot more sense also because clients would now be able to have access to a large comprehensive primary healthcare service and as an integrated service at a single service point. So for a number of reasons, it obviously does make sense, if we look at the single management team that in fact now runs all of these services. The funding, just from a funding perspective, the funding is generally split between ourselves and the City of Cape Town, with the portion that we pay across to the City of Cape Town via a transfer payment mechanism. And there are task teams that are looking at detailing the funding. I can talk a little bit more about that. I'd mentioned about Santa Cruz as the 10th facility. This was a new facility, in fact, built by the City of Cape Town that had been commissioned ahead of schedule. And it was obviously previously serviced by an outreach team from the city of Cape Town. And as part of the conversations that we've had with our city colleagues, we reached an agreement that we would take over the responsibility for the services at Visantekraal. So all of this happened on the 1st of July, 2022, where the 10 city clinics were then taken over by the provincial government on the 1st of July, 2022. And that's why I refer to it as a milestone event, because there's been a long trajectory, as I explained earlier, about this conversation that has taken place over many, many years. This is just a list of the 9 facilities. There's Durbanville, there's Parow, Durkee Eis, Heideveld, Nolongile, Scottsdene, Bellville South, Ravensmead, Nyanga, and then the 10th facility is Visantekraal. The transition, in fact, actually went quite smoothly. The transfer happened on the 1st of July. Just a couple of points to note. The property management teams are looking at resolving the ownership issues, because obviously the city of Cape Town would own the buildings. And the agreement with the city of Cape Town is that that will take place over a 12-month period, that they will transfer these buildings to the department, to the provincial government. Obviously, the city and provincial property management teams will work out what the cost implications of that transfer is and how that would be managed on the books of both the city and of the province. We have also already procured some equipment. Much of it some of it has arrived already. But where the equipment hasn't arrived yet, our arrangement with the city is that they would leave the equipment in place until the new equipment arrives. We have also appointed clinical staff, and in fact, they've commenced work already, and we're in the process of appointing the non-clinical staff, but in the meantime, we've made interim arrangements. Just perhaps some of the challenges that we had picked up. In changing service providers, particularly security and cleaning at the Nolongile facility, there were some challenges in the takeover. There have obviously been some processes and conversations with our city colleagues and the contact providers, and those have been resolved. And the colleagues from the team from the Metro had also met with various community structures. With regard to Ravensmead and Bellville South, we had consulted with the health committees. It included the Karl Bremer Hospital Board, as well as the community structures. But there were some community structures that were unhappy with the lack of consultation with all of them. And the colleagues from the Metro and team had then since met with all the stakeholders to make sure that everybody's brought on board. With regard to the issue of the transfer payment reduction, so part of the financial arrangement in the sense of our exposure in terms of finances is around 64.5 million. And part of that exposure and part of the arrangement with the city is in fact that we would reduce the transfer payment to the city by an agreed amount of 26 million. But there is a process in place for this, and the finance teams are obviously from Department of Health side and the city are talking regularly about how to put that into place, and there's been a general agreement around that. The remaining decision, the remaining city facilities, we obviously need to put in place a process over the next 36 months, is the time frame that we've given ourselves, to look at the remaining city facilities, because the intention is in fact that we would take over all of the city facilities. But we've given ourselves 3 years to look at how we can do that. And obviously, this was the first step by taking over the first 10 facilities. But our arrangement and our conversations with the city colleagues have been that we want to look over the next 36 months at the remaining facilities as well. There are some smaller facilities, and there's been quite a bit in the media about this. I remember at one of our standing committee meetings that had also come up previously. In terms of the city resolution C19A0121, the city then resolved at mothballing some of these smaller facilities by June 2022. And as a result of that, the facilities at Honeyside and Newfields were closed. In a subsequent city resolution, they amended the decision, the earlier decision, and agreed that the following facilities, which were part of that original conversation, would in fact remain open. So those being Elsie's River, Maitland, North Pine, Rocklands, Eastridge, Alphen, and Lavendale. So the city had agreed in their resolution 0422 that those facilities would then still remain open. We have always had a service level agreement with the City of Cape Town, and we are in the process of updating that service level agreement. It will, in fact, it is with the ED, and hopefully will, in fact, hopefully be signed today. But that service level agreement that we've always had, we've updated with the city that now includes this conversation about the 9 joint facilities with Visante Kraal, and then obviously what we talk about, the other facilities in close proximity, the ones that I mentioned earlier about the smaller facilities. In terms of our conversation with the city colleagues, we'd agreed that we'd sign the service level agreement for 1 year, ending 31 March 2023. And during this process, obviously, of the integration of the city clinics with our Department of Health and Wellness, if there are any issues that need to be resolved, we can then fix those in the service level agreement, and we can start a new service level agreement from March 2023 onwards. Honourable Chair, I think that's just a high-level summary of the issue, and through Minister, happy to answer questions.
Thank you very much, Dr. Karim. Minister, is there anything that you wish to add at this point? Will you respond? Thank you very much, members. Any questions? I recognize Member Baku Force.
Thank you, Chairperson. The Minister didn't answer all my questions, or the department didn't answer all my questions.
Member Baku Force, are you referring to the previous presentation?
Yes.
Can I ask you to, since we've moved along?
I asked how far is the
Member
process?
Baku Force, can I please ask you, since we are now on a different presentation, can you perhaps put your questions in writing, or we can deal with it as part of the resolutions?
Okay.
Is it fine? Do you have any questions on this presentation, Member Baku? You may proceed, Member, and then Member Barnes, and then Member Kego. Thank you.
I hope the department will answer all the questions that I'm going to ask now. I'm not willing to put this on writing.
Member Baku Force, the department is here. I'm sure they are more than willing. Please, if you do hear that your question is not answered, please do indicate so, but we can't go back now to that presentation. Please proceed, Member. Thank you.
Chairperson, before we leave the House, I reminded you that my questions was not all answered. I expected that when we got back, you will raise the issue.
Member Baku Force, we're not going to go into a debate in terms of that. That was
you.
after the session.
I'm just reminding you.
Yes, but that was after the session.
But you were supposed to.
Will you please go?
respond
Will you please proceed, Member Baku Force?
I will, but I just wanted to
I
remind
note.
you.
Thank you, Member.
Note that in slide 2, on slide 4, I just want to ask how much has been transferred to the city each year between 2019 and 2022, and where does the city account for the transferred funds? Can we resolve to call the city to appear before the committee to account for these funds and the quality of service at these facilities? And given the challenges experienced all these facilities, what is the department plans to improve efficiency? Thank you. I have a second question, Chairperson, which is on slide 6. What is the cost associated with procuring equipment, which is equipment was procured a facility and which ones has not arrived, and reasons for the delays? And what are the details of staff members that have not yet been employed, and what temporary measures has put in place? Thank you.
Thank you, Member Baku Force. Member Barnes. Member Tegel, and then Member Van Vogel in that order.
Thank you very much, Chair. My question is on the slide that was speaking about the smaller facilities.
Can you please just speak into the mic, member?
Okay. My question was on let me move. My question was on the smaller facilities that are moved into closer proximity. What I wanted to check there with the department, what's the alternate for the Philippi residents? My first question. And then the last one would be on the SLAs that are renewed annually, I think. What I also want to know is for how long have we been having SLAs, or is it just starting now, the 1 year agreements that are being signed? If I can just get clarity on that. Thank you, Chair.
Thank you very much, member. Member Tegel.
Thanks, Chair. Mine is on page 6, slide 6, in terms of staff, clinical and as well as non-clinical. Just wanted to understand that with the change that is happening, will there be any impact on staffing and careers of people? That what are the certainties that are there? Because any change result in uncertainties and people worry about their jobs. And then on page 7, on the challenges, that there is a challenge there regarding service providers. If we can get details of that what could be the challenge and how is it being resolved, so that we don't want in the long run to hear that there are litigations and then the matter was once brought in front of us when we didn't even try to detect what is going on there. And then on page 8, on the issue of smaller facilities, there is some sense of wariness on the ground about some institutions might be closed. So with the process, because the department is giving us assurance that there's no closure of any facility, but instead is bettering the service. And then yet on the ground, then people have got a different kind of feeling that some facilities might be closed. So I want to understand that if this whole process might result in any closure of any facility, and if any, then how will the service be able to reach the people on the ground? Thanks very much.
Thank you very much, member. Member Van Vogel.
Thank you, Chair. Mine is on page 3, bullet 4. What I want to understand, does the move towards single accountability health service include the integration of the 105 facilities that remain under the city? And can the department confirm that this integration will not lead to close of facility in the future and that no staff members will lose their jobs? And then, Chair, on page 4, perhaps if the department can also finish the committee with the following details for all 10 facilities: annual budget, staff complement including vacancy rate and breakdown per occupation, and in terms of population size served at each facility. And then lastly, Chair, when on page 8, when were those facilities closed and how many people were served by those facilities and how have they been affected by the closure? And also, where are the patients from those facilities, from those 2 facilities assessing medical care and accessing medical care, and what is the distance they travel to? Thank you, Chairperson.
Thank you very much, Member Van Vogel. My question was also on the Honeyside and New Fields. How does that impact the community in terms of service delivery? And then just a question of clarity, Dr. Karim or Minister. The 105 on slide 2, the facilities, does the department intend on taking over all those facilities? How do I understand it? Thank you, Minister.
Thank you for the questions. Just also probably to take you back a little bit, when we provincialized the rural, which the process took three years, and the thing was completed 2007, 9, I can't remember, 2007, for the provincialization of the rural health services, of which is now it's only the metro that we are talking about. So lessons learned during that time. What happened was about just to take over when the agreements were reached with the municipalities, and even taking over the properties as they were, which is the lessons learned is about taking over of the property. Some of them, as you probably may be aware, that in some of the clinics in the rural areas, they were attached to a municipality hall or municipality office. Meaning now, even some of them, they are still like that. And it becomes difficult even to do the renovations or to offer a full packages. Because as a municipality at the time that they were offering a limited package. So there are many of those smaller nyana ACs that are still there at the rural, and we can't do much. Therefore, it meant that we have to build some of the new clinics. Now, lessons learned from there, now for applying here, it's about we cannot just take over everything at the same time, including the properties and all of those. That's why at the higher level, at the DG level, with a municipal manager, city manager, and also public works as the Western Cape Government Public Works as a custodian of the properties. They're also working to the city in regard to what is it that we can take over, specifically in regard to those that now are under us, which is the 9+1. So that process is happening at that level instead of just assuming everything. Now, in terms of the framework, the National Health Act, it describes it clearly in terms of what is a municipal health service, what is their provincial health service. And then it says that during the transition, because previously the municipalities were rendering these health services prior 1994 through 1977 Act, where now in the transition period, it was saying that where there are still municipalities that are rendering services, health services that are supposed to be rendered by province, this should be through SLA, service level agreement. It's the same thing that is happening, like the eThekwini versus the KZN government. Similar, that is happening at the Tshwane, Joburg, and other metros that are running health services, which are supposed to be under province. Because in terms of the Constitution of South Africa, health services, personal health services, it's a responsibility of the concurrent function of the national and the province. And the National Health Act of 2003 stipulate that provinces are responsible for that. And the municipal services talks about the environmental health, the disease surveillance, which is like the TB, of their other outbreaks, for example, like the typhoid and so forth. So a service level agreement, it's part of what is in the part of the National Health Act, that we have to do that annual basis in terms of the package. And then what they do is about, in that agreement, which Dr. Karim may expand onto, is about what is it that they need to provide for us, because we don't want to end up doing services like environmental health. That is not our core function, but it is the core function of the municipal services. So in regard to because a member Bagufos was talking about even some, they need to come and account based on how they account to us, because it's that SLA, and also there's the targets, like the way we will say, if it's a nutritional services, it's about the child health, it's about XYZ, which is stipulated there in terms of agreement, is part of that.
noting it's not only the city that we do transfer money to. Just making an example, if there is a radiology, just making an example now in Vredenburg where we are using a private health, then there is that kind of agreement. We do those things. Or if it's done by the UCT or by the UCT or Stellenbosch, let's do that. But it doesn't stop this house chair to call the city, because there was a time that you have been calling the city and then they say they don't account to the legislature. So unfortunately, there's nothing we can do about it in regard to that aspect. Now, in regard to the, again, other smaller facilities and everything, what we are presenting here that we can account for, and specifically in regard to the response, is the 9+1. It's a 9+1, which already are under us. And it wasn't something that just happened overnight. They have to take it to the council. These are facilities that have been running for many years, both of us under the same roof. So now the difference is about if it was a mother and a father that were running the household, now it's being run by the mother only. The father is moved. So the children still have to be taken care of. Nothing is changing, except question is about which other parent, how are we going to make sure that now, because you are a single parent, who's going to be responsible for what the father was doing, which is we're confirming that the package of services is still the same. Nothing has changed. Just to make an example, I visited some of these even recently now that they've absorbed them. If the establishment had 6 professional nurses, and then 3 had 6 professional nurses, 3 were for the city doing the child health package of municipal services. It's a smaller package. It's a limited package. For us, we also include adult curative aspect of it and others. It means that we still maintain and retain the 6 numbers. There's 3, city took them. I think some of them are in the Brackenfell, but they took them wherever they took them. They are still employed, but in their own facilities. And then for us, we advertise the 3. In some of the facilities, like in the Durbanville, in the Belleville South, those ones who are part of the city, they applied. And then you'll find some facilities where it's actually the same faces. But now the 3 that were under the city will have applied, and then they applied like anyone else, and then they qualified, and then they are part of that establishment. Or others will have gone, like for example, when I was in Centre Tukral, 2 of the professional nurses that are working there, one was working in Durbanville, and the other I can't remember where. So it's something like that. Standard is about the same number of the staff that were there, but the city will have taken theirs, but anyone could have been able to apply. In regard to the other smaller facilities, I think Dr. Karim there was just a courtesy in quoting the city document. It's a city document that states that in terms of the plans related to the facilities that are less than 2 kilometers nearer to each other. It was quoting the city document about the facilities that they initially were planning to close, but now they remain open. It's not us, it's their document. Because when they have to close, if they intend, it's a collegial thing that if you intend to close a facility, those patients, it means you have to absorb those patients. So it's a good thing that you need to inform us so that we could be able to plan ahead. So it is their document. So the question about what's going to happen with the smaller facilities if they are closed, at this stage, there is no confirmation that they've brought to us, except their document says that those smaller facilities they intended, they remain open. About the Newfield and all of those, they are city clinics. So therefore, we cannot be able to respond, is that why did they close Newsfield? And anyway, patients come to us. And then the other part of it is about, okay, I've responded about the impact of the closure, but the other thing, it's not the first time actually we are doing this. If you recall, Ngonde, through you, Chair. Michael, your city used to have a child health clinic before we have the Mapongwana, which is we absorb that as part of the Michael the Bothasek clinic, which is a CDC now, which is under us now. It used to be under the city. But with the older persons now who had to go to Derky Ace in Goodwood in the fourth tracker, they indicated that they want to have now an adult curative because they are using chronic medication, which the city package, it's a limited package. And I'm only making an example of a primary school and a higher primary school or high school. CDC, we can say CDC, CHC is a high school. And then the clinic, it's about primary school. So they are saying now we need packages of care that are at the high school level. It cannot be that we still have got only for the child health, also only for the minor ailments for the adults, because you are sick, you chronic medication, you need to see a doctor, of which the city said that they don't have those resources. Province take over, which is now is under us. That Bothasek. It's similar, I think, with the retreat for the oral health and all of those. It has been happening. Danun, which now I recently opened this week, the maternity unit, 24-hour maternity unit. It used to be a city clinic, which now we ended up absorbing, and then we built that Danun CDC. We opened, I think, in 2018. It was part of the city. So there are many of the instances where it has always been like that. But this process now, it's a process where we are realigning, going towards provincialization, which we have done it in the rural areas. So where I'm sitting, Chair, there are no provincial government health facilities that are intended to be closed during this process for those that are provincial government. The 9+1, it's still happening, because I'm saying +1 because Fisantekral has always been under the city. We didn't have a joint. We're not there jointly. It was the city that built a new clinic. But now, again, the people there now require a high school level of care, not only the primary school, which the city said they are unable to provide because it's a clinic, provide that care. Now, province, will you please take over so that you increase the package? Lastly, city with their 100 and something of the facilities, 13 of those do provide the comprehensive package. All other clinics, they provide everything except the adult curative care, which is, and then full-time doctors and pharmacists, because there must be a regulation, act, legal aspect that you have to meet when you are providing that. Just to make an example, at a clinic, nurses, it's nurse-driven, doctor-supported. They prescribe everything up to Schedule 4. Schedule 4, it's antibiotics like amoxicillin and so forth, without necessarily having a doctor. The doctor might come maybe once a week for those patients who have been referred, or for those mummies who are coming for the first time for antenatal care, just to be seen for the doctor once. But it's not necessary, there is a doctor full-time. So they do their consultation, and then they give you medicine from the cupboard, they give you in their rooms. That's how it works with the clinic. You don't get the other packages, like there might be a dentist or oral health or occupational therapist and so forth. There is no one who deals with the diabetes, except you can do the screening, but there's no such. Now, in the CDC level or CHC, which is what they are asking for, is you get all that package at that level of the city, plus also what I'm talking about. So in the city, they do have 13 out of those, like Mamu Ukivits, like in the one in Bela, it's a CDC. They do provide that. I think also the one also in Kailicha is also provide that. But in some instances, they will say you won't be able to provide as such because it requires a lot of resources. So that's how things are when it comes to government. Provincial government at this stage, there is no intention of closing any of those that we have absorbed. It still goes, things go as they were in regard to the packages of services, but now they are only offered only by the province. The number of staffing is still the same. It might be not a city staff, but it might be a city staff, but appointed by the province. Thank you.
Thank you, Minister.
Dr. Karim.
Chair, Honorable Chair, thank you. Just some of the additions. The total transfer to the city that we make is 680 million. That's for PHC services, for HIV, and for some medication. So that's the total amount of the transfer that we make across to the city. There was a question on the equipment. The total exposure for the 10 facilities to us was 64.5 million, of which around 10 million is for goods and services that would include equipment, and they're really small, relatively small items. Not a long list, but we can certainly make that list available. And where the equipment hasn't arrived, cities agreed that we can borrow the equipment until such time as our equipment does arrive. So it's 10 million out of the 64.5 total exposure is for goods and services. In terms of, as Minister explained, the staff, what the city's done is they've retained the staff who worked in their clinics and they've redeployed them in other places that they needed the staff. Hence, we obviously had to go out and advertise for the professional and for the non-clinical staff. And we've appointed our staff already, and we've obviously run the process and started before the transfer so that by the time the transfer takes place, on the 1st of July, that it's a smooth transition. And to be honest, we were probably expecting a lot more challenges than we actually then experienced, but it was a smooth transfer, a smooth takeover. So the city retained their staff, and hence, obviously, we will reduce the subsidy to the city. There was a question on the smaller facilities. So there are also 9 what we call smaller facilities in close proximity. And if I can link that question to the one on Honeyside and Newfields, that yourself also, Chair, added to the question. So when the other 9 what we call smaller facilities are in very close proximity to where we also have big clinics like Newfields and Honeyside. So when those closed, the staff, the services to the communities for Newfields and Honeyside were then offered between Hanover Park, Silvertown, and Dr. Abdurrahman CDC. So it's obviously in fairly close proximity to where we've already got fairly big services that are functioning. And similarly for all the other 9 smaller facilities, what we call smaller facilities, they in fact in close proximity to provincial facilities. But the city resolution was that they would remain open for now, and they obviously will become part of the bigger integration of the 105 facilities. There was a question on the service level agreement. It is just for 1 year, because in this year until March 2023, it will allow us the chance to, if we need to make any additions or corrections, given how the transfer process has happened, then we can make those amendments, and then we will re-sign another service level agreement from 1 April 2023, if there are amendments to be made. The impact on staff, I think I've answered that in terms of retention. So the city retained their staff, and we obviously employed new staff on our conditions of service. And as ministers explained, people could apply for posts if they wanted to work on provincial conditions of service. There was a question on the service provider details. I think it was referring to Nolengile in terms of the security and cleaning. We can certainly make available the names of the companies, but in the security side, what happened, the city obviously stopped their security contract, and we employed through our Department of Community Safety security services to make sure that there's retention of the service. On the cleaning, there was also switch over a tender process of a different company that took over, a different contractor that then took over the cleaning services at Nolengile, and that's what happened there. In terms of the list of services that the city offers versus what we offer, and I mean, it's a long list and it's in our service level agreement, but I'll just give through the Honourable Chair, just members a sense of it. It's promotive, preventive, primary level care treatment for minor ailments. So the city has the ability to do minor ailments. There are children's primary healthcare services, there are maternal, reproductive health services, there are sexually transmitted disease treatments, the HIV program, which is also part of our general transfer subsidy, which of 680 million. There's TB treatment, and there's some adult curative services that the city provides. There's also a list of some specialized services like epidemiology, like quality assurance, like some x-rays, like pharmacy and drug supply, and hence that's also part of the drug medication is also part of the transfer payment to the city. On our side, obviously, we'll continue with all of those services, but add to that what we normally would do, which are curative and specialized healthcare services, treatment of chronic patients, the 24-hour emergency service, maternity hospital services, laboratory services, disease outbreak response, etc. So it's a combination of all of that, and that's a list of the city clinic services under the Municipal Health Act versus and our services. Minister answered the question of the closure and the integration. Obviously, there's a process of over 36 months of the rest of the city clinics and the integration of those. I think there was a question on the details on the 10 facilities in terms of a staff breakdown. We can certainly make all of that available because, as I've said, we've employed the clinical staff already. And I've answered the question on Newfields and Honeyside. And like Newfields and Honeyside, those other 9 facilities that are in close proximity. As I said, we have very large CDCs or CHCs in very close proximity to those 9. But in terms of the city resolution, they've decided that those would remain open for now. I think, Honourable Chair, Minister, I answered all the...
Sure, Minister.
Add that in addition to the Durbanville specifically, there are mobile clinics for Durbanville because they've got the city has been servicing 59 farms in the Durbanville, the Philadelphia, the Middle Post, and all of those up to Clearville, all of those. So at this stage, which is we also have to inherit those. The equipment part of it, those mobile buses, fancy ones, they belong to the city. So just in case that there might be other farms that they are still trying to service, is because if now the city has taken some of those mobile back, for us, we have to fit in some of those. So the last time when I was there, they will have started because they spread it. I think maybe 10 or whatever farms each and every day. There's a day for each after 5 days. So we are still trying to get some of the mobile buses that are used from the, similar ones that you normally have for the rural areas, in case the city now takes over, because take their buses back. So just to let you know that the Durbanville Clinic was also, it's not only the Durbanville Clinic, it includes also the mobile clinics for the 59 farms in Durbanville.
Thank you very much for that additional information as well, Minister. Members, at this point, can I move over to the community reps present? Member Barnes, do you have a pressing question?
No, Chair, it's a question that I've asked earlier. I can't remember getting a response on that one. It was the one on the alternate of Philippi residents. Where is their clinic? Where are they going to? I've asked specifically about Philippi. Yeah.
Oh, we don't have Philippi for which clinic?
I'm asking the community of Philippi. Where is their alternate clinic? When they go to a clinic, what clinic are they using?
Okay, but it's not part of the 9+1. Philippi, they've got a Welterfrieden, they've got the non-Zame. There are no changes in the Philippi. They are not part of the 9. They are not.
So there's no clinic at Philippi.
There are many clinics in Philippi. The point that we're trying to highlight is that in the 9 facilities that we have absorbed, Philippi is not part of those. There are no changes in Philippi. So the status quo still remains
So there are no changes. It is what has been happening throughout. There are no changes. In fact, I was giving an example, some other clinics in Philippi or Nonzame, the Weltefred and all of those, even the one that the city closed because of the sewage surrounding, I can't remember which one is that one. They fixed the sewage now, which is that clinic that belongs to city will be open. So they are not affected in anyhow. There is no clinic that forms part of this as part of the Philippi.
Happiness Member Barnes. Thank you very much. And then I also see that we have another guest, ma'am. Good day to you, and thank you for joining us. Can you kindly introduce yourself for the record, please?
Good morning, everyone. My name is Joyce Malibo. I'm from Guguletu Health Committee.
Thank you very much, and a warm welcome to you. It's wonderful to have you with us this morning. I will now afford the opportunity to our Health Forum representatives if they would wish to pose a question. I see Ms. Kivitz's hand and the sir at the back, the two hands. Thank you.
Thank you, Madam Chair, for the opportunity. I would like to take the Portfolio Committee back to the sitting with regards to the budget that we had earlier in the year, where the 9 clinics that was pending closure came under discussion. We as the Health Forum raised the concerns around the possible amalgamation of services. We were told in this house that that's not the case. So from where we're sitting, if the department is serious about engaging those concerned and involved in the amalgamation, because if we look at the list of clinics in the amalgamation, it's not the same list that the department said they were going to take over from the city. So as the forum, we would like to ask the Health Portfolio Committee in your recommendations to go back to that initial sitting where we raised the concern around amalgamation. Because if 9 facilities is amalgamated, it still raises a concern for the community with regards to the facilities that are not taken over by the province. When the province in 2014 took over the services in the rural communities, it did not take over some of the facilities, it took over all the facilities. And we thought that was going to be the case in the metro, because the amalgamation has been part of the discussion since the late Ivan Tom's and Uncle Polly's days. And so here it happens, there's no discussion, there's no engagement. We had to force the hand of the HOD for a discussion. The discussion took place on the 3rd of July at Bishop Lavis. Then we had a discussion with Dr. In the Kalbrema facility. And I must commend the Tygerberg substructure because they took us along with the entire process. But the amalgamation of the rest of these facilities, the communities were left out. They were not included in the discussion. So the one day the department say we're going to have the discussion, and with all due respect to the nominated health committees, Madam Chair, the nominated health committees in most of our facilities don't understand their role. We had a situation at the Durbanville CHC where we asked, so Durbanville, like the minister said, with the farming communities and the mobile facilities, what's going to happen now? The chairperson appointed there were not even aware that Durbanville is a facility that sees to Morningstar and all the other surrounding facilities. So for us, the department and the portfolio committee needs to come to an agreement of how do we engage when serious things like this impact service delivery for communities. And I must commend the MEC, give her the due credit is due, is on the 1st of July. She went to Durbanville specifically. We thoroughly appreciated the fact that that is what she did because we watched the scene. Our foot soldiers were on the ground. And I think we need to steer away from the us and them portfolio chairperson, because when we say we want a collaborative service around this amalgamation, it impacts people's lives. It doesn't impact people's lives. That doesn't matter to us. People in communities matter. And so when they want a comprehensive service, they're not going to look at who renders and who don't render. Child health is still a serious issue, and we need to look at how we're going to address it. Because if we raise the question in March, the department knew they were going to do the takeover. Why didn't the training for the community, the IMCI nurses, start then already? So now at some of these amalgamated facilities, we still have children being turned away. And I think that leaves a very, very bitter taste in most of our mouths. My last comment is around the St. Vincent Clinic that the minister just said. That is a classic example of a partnership that has gone horribly wrong, because that was a dual facility. Province moved out, Province then ended up in Symphony Way. What was left is a service where the community is really up in arms. So when we do these kind of things, let us not come along when the decision is made already. Let us come along when the decision is taken, because then we are talking about primary health care approach according to the Alma Ata Declaration. Thank you.
Thank you very much, Ms. Kivitz, for your input. I'll ask the Minister to respond, but I'm just going to afford the opportunity to the gentleman at the back at the same time.
Response? Yeah, okay. Thanks, Ms. Kivitz. Probably because English is not my first language. I don't, the word amalgamation, for me, when I'm sitting it's not necessarily applicable to the 9 facilities. And she's saying that these are not the same 9 facilities. There is no way that they are different, because that's the only facilities that Western Cape government and the city of Cape Town are working under the same roof. So you cannot change that. It's a fact. So all these 9, we are all in the same roof. We have got the city that side, we have got the province that side, we have got the facility manager in charge of the city, facility manager in charge of the province. We have got in some areas like at Durbanville, they use the same system in terms of the clerk and all of those. So that is not the same. Mamukivitz needs to demonstrate that which ones that is talking about, because that's the only facilities in the metro that we have been all together. That's why they are prioritized. Some of the aspects that led to, in terms of the that now one sphere of government, was you are putting 2 spheres of government under one roof. It was about the working conditions are different, the same. If you are a professional nurse working for the city, professional nurse working for the province, the work conditions in regard to the hours of work, the salaries and everything is different, but that's not the point. The point is about, like when the last time I went to Nolungile, you go same entrance, you go to the same clerk administrator, and then let's say I'm the mother, Auntie Sarah, with my child, coming for the child who's ill or is coming for immunizations. You'll be directed to the city side because it's a package of care they provide, child health. And then once you are done there, you are saying that, I'm also coughing. I think I've got a backache. The response will be, we don't do adult curative.
go to the provincial side there, meaning now you're going to go that side and start another queue because it's another sphere. Also an example, one time I went to Nyanga, which is also, it's part of where we are, for example, together. There was a spill, some on the floor, it was milk or something, part of the outpatients. And then someone called, someone please clean. And then there was a cleaner who came and with a mop and everything. And then she said, it's not my area. It was my area, I cleaned it and then turned it back. And then I said, but what's the difference? It's the same thing for us as community and everyone. It's the same thing. He said, no, actually, I'm supposed to be now off duty. That is the province side. That's not my side. Now, when we move, this other example is Bothasech. When we move out of Bothasech, it was a city clinic where we were all together. I recall at the time it was part of the initiative by the former councillor Force, who was the ward councillor there. When we moved in, there was the whole package of a CDC kind of, although it was a clinic, the pharmacy and everything, up to the level that the tensions that were happening there in regard to taking responsibilities and so forth, it made it that we'll find that not only about that, but their resources, who's supposed to foot the bill on A, B, C, D, E. We ended up pulling out. I think we went to Scottsdale, pulling out. But unfortunately, correctly what you are saying, that when these things happen, it does actually impact on the communities if the packages drop. Because once you provide a package of care, irrespective that one part is not utilized much, you cannot pull out, no matter what. So when we pull out, the city, unfortunately, were unable to continue with that adult curative package of care. And then they ask us that, please take over, which is what is happening in Fisantecral. And then we went back and then we took it over. So what I'm trying to highlight is that if I make an example of this house has got 42 members, and it is a house of parliament. Irrespective that the one MPL is Mbombo, the other MPL is Member Barnes, but Oksalayo, the decorum and everything about the house needs to deliver. Same thing with the 9 facilities. There are CDCs, CHCs, Paro CHCs, Degay CHCs, others are saying CDCs. The package cannot change. If child health immunization of the children were done by the city as part of the city package, still there will be packages of immunization child that needs to be delivered, because it's a definition, it's a framework, it is also a template of what the CHC has to deliver. It has to deliver. No matter who does it, when I'm making an example of that, no matter who does it, has to do it. But luckily, we didn't drop the numbers where we say, city, Ravensmith, for example, go out, you are going out, and then we are left with a shortage. No, it was about in those consulting rooms that were meant for the child health is still going to continue. That probably now you may not have the child health in that side. Eastern wing is city, western wing is province. You can do internally, but the same packages are still part of that needs to continue. And then lastly, with the Durbanville, because I highlighted this on purpose, because I get a confirmation now that actually the team has already initiated in terms of that. The only stumbling, it was about the type of vehicles, because city already purchased newish mobile clinics and more fancier compared to ours. If you look at ours, they are not as fancy. They are probably Corolla, maybe they've got Mercedes-Benz, sort of. I'm making an example, I'm exaggerating. So it was about now, because the community already have been exposed to this type of service, the kind of the mobile. So at what extent that now the management can able at least to assist them with those? Because when I went there, indeed, the one that they had, it was just one stretcher, that's it, without a separation. And also it didn't have, we do have actual newish ones where at least you can even have the fan, air conditioner, and also you could be able to have some part of the electricity and also all of those. So that was the only stumbling block for that. But already There are teams of rendering those mobiles services to the 59 Durbanville communities. It still remain the same. Like I know that Fridays, Clear Beerville was part of the Fridays. Tuesday was part of Philadelphia because I was going to visit them. So nothing has changed. The only difference about it's no longer Mbombo who's bringing the service. It is Akona who's bringing the service. Same qualification, same everything, same skills, but the only difference, the community that you know, is that whether Mbombo is appointed by the province or is getting salary from the city, that's the only difference. Dr. Karim?
Minister. No, I think you've answered them well. Just in terms of the plans going forward for the rest of the 105 facilities. Obviously, we're working with our city colleagues over the next 36 months, and we could be guided by the minister. And she obviously will liaise at the political level, obviously with the MACO member again. So there's obviously conversations that happen at that level. We, from a department side, from the official side, will work with the city colleagues on the other side. In terms of the technical operational details of the transfer, and Minister will resolve the political level of conversation. And I must just say to the House, the Minister has been working hard at resolving the political issues, and it's that brought us, in fact, to the point where we have been able to take over the 10 facilities. I think I think our Minister's had. Thank you, Honourable Chair.
Then the gentleman at the back, and then there's Ms. Isaacs' questions.
Okay, my name is Kwezi Chacham from the Nyanga cluster. I will say firstly, maybe the department maybe needs to go around to check the nine that have been moved to the province, if they are oiled enough, they are working properly, just to have a more proper report on the community, because maybe we are talking about the one side of the town, but we don't know what is happening in the township, because I'm coming from the Nyanga, which is one of the 9 that is there. So it's a concern from my side. The one thing I have to say, that is one more concern, because Nyanga is a very large area which is clustered with Masingedane, which is part of the KTC and Nyanga. The problem there that we have facility managers. We had a facility manager that was there before. And then after 3 months, six months time, the facility was changed to another acting. The other one was acting, and we have another acting facility manager that is there. Maybe the department will help us on what is going to happen again, because the problem is implementing the stuff that we are, the plans that we have with the facility manager. Because it's very difficult to go to the community and introduce another facility manager that we have just introduced now. So I don't know if it will be acting, and I don't know until when. I don't know if there's proper plans from the department, maybe to have a permanent person that is there. Because if you are not permanent, you're not going to go full force providing the services to the communities. You're not going to go full force making sure that your clients have been provided proper service by the department. So that's our concern from our side, because we've been changing and chopping facility managers. Thank you, Chair.
Thank you very much, sir. And then Ms. Isaacs, your questions. Do you have the questions, Minister? You need to Okay. Thank you, Minister.
To the wellness facilities.
Yeah.
The wellness hubs that we want to have in our communities.
Yes, and the lack of facilities, the availability thereof.
Yeah.
And as well as, I think you made mention of youth with mental issues, support to the caregivers.
Yes, support to the caregivers when they are admitted with meltdown, where they're being brought in by the police, and we find that parents and whoever the caregiver is that brought him in is just as in that emotional state, and there is no service available at that moment for and the support afterwards for that caregiver.
Thank you very much, Ms. Isaacs. Minister Mbombo.
Okay. I'll come to Ms. Isaacs. The question about have we made a follow-up on that? From my side, I've done the follow-up. From the substructure side, actually, the substructure district managers, that they've actually been prioritizing the visits into these areas. I know, for example, Belleville South, I know, for example, Nyanga, specifically because you asked for the Nyanga, and then the whole, of course, the Nolungi, because there was an issue about the tender security and the cleaning and all of those. Mr. James Kruger has been following up on those. The Fisante Kral and all of those, that's what they've been doing. And also in regard to the clinic committees, which I've engaged with them, that has been part of that aspect. Of course, when we come to now just making the ownership of this, it doesn't mean that there were no other challenges, generally for health service delivery. For example, in Nyanga, the issue of waiting outside and the whole issue of the long queues has been part of that. It's not necessarily that all of a sudden now, when it's owned by the provinces, everything will just automatically become smooth. It's part of the ongoing processes of improving patients' experience and also quality care services. Masnedane Tata is under city clinic. Masnedane is part of the city clinic. It's not part of the Western Cape government, but I just hope that the city is also listening in regard to the issues that we have raised. But it definitely, Dr. Karim will also take up with them in regard to that aspect. It's one of the reasons, many other reasons, that one sphere of government needs to take responsibility of the healthcare services, because the other part of it, of this one sphere to be responsible, is about that kind of questions. You get people asking, what is going to happen to Zakele Clinic? What is going to happen to Mesneta? And then when I say that, no, it's not under me. But you are the Minister of Health. But I'm Minister of the provincial government. In as much as that I can raise the issues through intergovernmental framework or ask my colleague, the MMC for Health, to deal with these issues. But people there, they make an assumption that I'm overall responsible for each and every health facilities, which I'm not. So it's one of those things where at least the buck has to stop somewhere in terms of accountability and also of the responsibility. So indeed, for Semingatane, we will take it up with the city. And then lastly, now, Mamo Isaac, I did respond to some whilst we're on tea, but the issue of the mental health for the adults. That's why at the budget speech, I committed additional 30 million specifically for the adolescent health and the adult, we call it geriatric psychosis. Because with the COVID, we have seen large number of adults and older persons specifically presenting with depression and anxiety, as we know that specifically among women, because these are the people who have been caretakers, who have been nursing not only the sick family members who were ill during the COVID, but also for those frustrations when the services were not open to everyone. And also the issue of feeding, unemployment, feeding the grandchildren and everyone, even using their grants. They actually bear the brunt in regard to the post-COVID sense, the mental health, not only in the Western Cape, not only the country, internationally, hence the additional 30 million specifically for those two areas. Currently, which has been happening, where we are strengthening mental health services at the community level. Because I think that's what I was responding yesterday here in the House, that because people, like you are saying, that we are bringing your son or your daughter, whoever, to the clinic, you are also affected, especially in the circumstances where you'll find that they have to take care of these, children or youngsters with substance abuse. So the packages of care in clinic, CDC, it's a mental health. Mental health is part of the primary care. So you must look at those, not only focusing about Lendegeer, Falkenberg, and all of those. As a result, there is always in every package, CDC and CHC, there's an advanced mental health nurse. There might be one or two in others. That is there at the clinic. Their responsibility, in some others, they come once a week, but it's mostly in the rural areas. I think in the metro, in most of the areas, they are there throughout. In some, their responsibility is about following up of those who have been diagnosed of mental illness, probably might have been admitted in the specialized mental hospitals, but now they've been discharged so that they could be able to be followed up and to be checked how is their condition. So there will always be that nurse, advanced mental nurse who's there. Secondly, it's about when the others are consulting general patients coming in as much as that almost all our professional nurses have got a black bar, you must check their epaulets. When you wear a black, you must know that is a qualified mental health nurse as well. In as much as that, but they could be able to say, this one needs a further consultation, although she came for coughing and so forth, but I can see that she needs some counseling or that maybe some assistance on mental health matters. Go to room 4, which is advanced, because it's a specialized mental health trained person, can go there to that room for mental health nurse. Also, in addition, and now for psychiatrists, I think Dr. Karim is a person who's in charge of the clinical whole thing of the operational. Even was previously the psychiatrist, you have to wait for it, you have to refer the patients to the specialized hospital to be seen by the psychiatrist. But now they are able now to be able to come to be able to provide support for those cases that will have been identified, so that especially for these older persons, plus also for the young ones, instead of them being there at that level. So we're doing as much as we can for the mental health, also referral to the social workers and also to the clinical psychologists as part of the additional funding that we received in regard to the interns for the department. Instead of putting the whole of those money only to the medical interns, there have been many of the clinical psychologists as part of the interns, because they have to do internship, that now the department is appointing so that they could be there at the primary healthcare services in regard to that aspect. Thank you. I think for the wellness, I did respond to her when was there. Over to you, Dr. Karim.
Dr. Karim?
No, nothing to add, Honorable Chair. Just I know at Nyanga facility, the clinic manager lost her husband a few weeks ago. So there was an issue there, and I know there was an acting person in her place, but I know the services had continued. Obviously, we had to put in place an acting person just to help there. No, I didn't want to add anything else, Chair. I mean, we obviously just back to the question of the 9 facilities in close proximity that we also referred to. We also have a list of those 9 facilities, but I mean, obviously, if members want, we could make that available to yourselves. Thank you, Honourable Chair.
Thank you very much, Dr. Karim. Members, I think that pretty much rounds it up. Member Van Vogel? Remember your mic, please, for the record.
There was, I asked a question in terms of the 2 facilities, the Anniside and Newfield facility. I'm not sure was it answer, and it's really a problem. It becomes a problem if we are pouring money into the city, millions, and there's no accountability. Because as it was mentioned by the minister, they refuse to come and appear come and appear in front of us because there must be accountability. We are pouring in money, millions of rands. So for me, it's unacceptable. Then, Chair, I think, I just need clarity on that. I think Dr. Karim mentioned of covered me in terms of the 9 clinics. The minister mentioned something, English is not our mother tongue, so we are trying our level best. In plat Afrikaans sou ek sê die 9 clinics. Because I really want to understand. So when I spread the message outside, I'm clear. Are you saying the 9 facilities of the 9 klinieke wat julle noem, wat onder die city val? Daai 9 klinieke gaan nie toe nie. Dit val nou onder die provinsiale regering. So I just want to understand. I just want to get clarity on that.
Thank you very much, Member Van Vogel. Dr. Karim did make mention of the 2 facilities, but Doctor can repeat himself and then your clarity in terms of the 9.
Yes.
In mooi Afrikaans.
So Newfields and Honeysuckle, Honeyside clinics. When those were closed, they part of what we call smaller facilities. So they part of the 9 facilities in close proximity. That's a different group of 9 from the 9 we've taken over. When the city closed Newfields and Honeyside, patients, the services continued from our side at Hanover Park, Silvertown, and Dr. Abdurrahman CDC, which are all fairly in close proximity to Newfields. So that's what happened there. And as I just said, now there are other facilities in close proximity that the city, by terms of city council resolution, they've decided not to close. And that's part of the second group of 9. So I can give you those names so that you have the answer. Those clinics are North Pine, Elsie's River, Rocklands, Eastridge, Elfin Clinic, Lavender Hill Clinic, and then obviously Honeyside and Newfields were part of that group, but I missed one. I missed Maitland. Yes, I missed Maitland Clinic. So those are the facilities in close proximity that, other than Honeyside and Newfields, that the city decided not to close. So those are still open in those. The other 9 that we've been talking about, the 10, let's call it the 10, those are the ones we have taken over. That was the shared facilities. Yeah, those are on the slides on slide number 5. So when you have the presentation, the clinics on slide 5 are the shared facilities that we've taken over. And the list that I read out now, that's not on the slides, are the facilities in close proximity that by City Council resolution, they've decided to keep open, other than Newfields and Honeyside.
You covered, Member Van Vogel? Yes.
I just want, in terms of because Dr. Karim mentioned that the budget was 680 million. So are you saying if the city refused to come and see us, we can do nothing? Is that what you are saying?
I don't know exactly at what extent the powers of the legislature could be able to do such when it comes to local government. However, in our case, government to government, like on monthly basis, I've got a one-on-one with my counterpart from the city. Also, number 2, we have got what we call intergovernmental IGC. What is the C?
Intergovernmental.
Yeah, that part of it, it is co-chaired, it's the premier and the mayor, and any items on the agenda are related to whatever department. It could be libraries for sport or us for the city. The 2 us together with the executive director for health that side and also the HOD do make a presentation, and anything that needs to be resolved, we use that platform. So we do have that part of it. And then as part of the annual service level agreement, if they want to add anything, like that's why he was saying that they are still busy with the one that expires in 2023, so that we can add if there are any other aspect that we want to add them for them to do. For example, for this one, because now we have taken over the 9+1 for Santa Cruz,
the 9 that were shared plus 1 that they said they won't be able to be taken over. Now, that's what they are saying, that meaning you are going to get the budget less of the 9 plus 1. So I think it's 25 million, something like that, less. 26 million less because of that. Let's make it an example now. For 23-24, if the council, the city now says that they are letting go of the other 9, the reason to do it in phases instead of doing the same approach we did in the rural. The rural, actually, we didn't, there were many, I think I did mention the issue of absorbing some of the properties that actually we end up not being able to utilize. It's about, firstly, the ones where we are all together, which is the 9. Secondly, it's about where they are nearer to each other. And then thirdly, it's about the whole of the services so that we don't absorb everything at the same time. Specifically, that you don't confuse the public in that aspect. And also, secondly, it's about, you don't want to see, let's make an example of Mitchell's Plain. In the Mitchell's Plain, where the other smaller facilities, I think it's rock, it's a Rocklands, which is part of that. If you look in terms of next to Rocklands, what are the other services that are there? They also include ours. So in as much as that, technically speaking, when, and also in terms of the norm for health services, it says at least a 5-kilometer radius, there should be a service that Auntie Sarah can even access or even walk to. I'm talking about the rural areas walk to. If it's beyond that, it means you have to bring it back. That's a quality kind of what is supposed to be delivered. If now we have got many of those, not only less than 5-kilometer radius, but even 2-kilometer radius, the definition, it end up activating that there is part of the oversupply if it's a repetition, or if it's the same thing for 2-kilometer radius. So it is their justification for that. But as Dr. Karim is confirming now, their document now suggests that those other 9s, they're going to put on hold. They're going to remain open, whatever reason they have. But they'll let us know in the next phase. Probably they want to see the phase 1 now of the shared facilities, and then they see then afterwards. Back to the question of the accountability, government to government level, there are elements of accountability. Political heads of the government, the premier and the mayor, there are levels of accountability. The only issue, it's about the issue in relation to now the oversight, the role of the legislature. At what extent that now you could be able, for example, the issue of Masnedane is a city clinic. The issue of the others, the other 9 and the others, is a city thing that you want to ask them. Actually, so I'm going to close them. What's going to happen? How do you feel about whatever, all of the, what we're going to do with the money and all of those? We are giving, because it's you, it's a committee that when we make a presentation for the appropriation, when we say going to the city, you approve or not, and then we divert the money, we send the monies accordingly. You want to follow the money and see how that 680 something, what does it do? So at what extent that you could be able to do such, I don't know. So probably what I'll suggest, I don't know how it works with the legislature, probably the committee, maybe through this speaker's office, I don't know how you can be able, whether they get subpoenaed, I don't know, that you want to follow the money. But the argument would be, what about other service providers where we are sending money to, like give NPOs quite a lot of money for some of the, not only community mental health service, but all other stuff that is done by the NPOs. We are giving the universities other monies for the level 3, Grooteskier and so forth. Like now, we bought the robotics. Just making an example, although they do it for the Tiger Bag, but it's also linked with the professors or even universities. At what extent can you even call them to come and account when you see there is a large number of money that goes to the universities? As I made an example, that in some instances where the radiology or we ended up getting the private to assist us with some of these machines instead of us having so much cost for the people when they need radiology to come to us, like in Vredenberg, and then we use the private. And then how much money we send it there, at what extent you can call that private to come and account that you are getting, let's say, 5 million per annum from the department. How do you ensure that you use the money, because it's taxpayers' money? So we mustn't only look chair only for the city. There in that APP or APRF, just check where else, but specifically for service delivery, where else we are sending the monies for the service delivery. Follow the money, call them to account. How to use the taxpayers' money that you are getting through the government. So that not only come the city where they feel like they are being now called for blah, blah. So there might be the city in this table, there might be private help, there might be NPOs, there might be whoever that is part of that. Thank you.
Thank you very much, Minister. Just for the record, we have had the city previously and we didn't have an issue for them coming. So I'm sure in terms, if the committee should resolve, we can accommodate in our program. Members, at this point, I think this is where we conclude our meeting. I want to say thank you to the Minister of Health and Wellness. We also now understand better as to where the wellness part fits in. And I think it was important to have this engagement, especially in terms of the public perception of, facilities closing down and people not having access to care and so forth. So thank you so much, Dr. Karim. Ms. Champion, thank you so much for your time as well. Mr. Mele, for you also being here this morning. We greatly appreciate your input and your indulgence of this committee this morning. I also wish to extend on behalf of the committee, our sincere thanks and appreciation to our Health Forum representatives. Thank you for the extremely wonderful work that you are doing in the communities as well. And it was an absolute privilege for us having you here this morning and engaging with us and the department. Thank you very much and go well. Thank you. You are excused. Members, for us, we just have one more item that we will attend to.
Well.
Go well,
So they
Minister.
don't have to go to clinics.
Did well first.
Kufunile list naleya members. Okay, leya ithunyelwa la magama. Yana lithumele phela sepapa. Oh, okay, I'll send.
So members, Member Tejo tendered his apology as another commitment, and then Member Frey will also leave us in the next 5 or 10 minutes. You will also be excused. Members, we will have a... Yeah, let's go to the resolutions first. Mama's before you today, Member Banford.
No, I just want to caution you, Chairperson, don't behave as you are the department. We've been going a long way together. Now you are starting the things that I forgot about. You can't allow them to answer unless they are saying they cannot. Now you are the one who are ubahambela phambili, man. I don't know, but I was disturbed because really Not Noma French. The MEC didn't answer the question. You were supposed to say to her, if she can, as usual. If she cannot, she was going to say, no, I just passed that, or she will answer that. I was really disturbed about that. We are coming a long way. Thank you.
Thank you, Member Bakufos. I tend to disagree with you on that one. We must be reminded that at the beginning of this meeting, and I mean, we are supposed to conclude at 12, it's 10 past 12. And if we say that we need another session, then the committee must accommodate another session. But we cannot go on and on and on. When we say we have an hour, then we have an hour to our disposal. And I think it's not fair towards those community members that came all the way not to grant them an opportunity as well.
Chairperson,
No, member, give me an
let
opportunity.
me
No, you must give me
a point of order.
No,
on you.
member,
No,
you
let me
spoke.
call a point of
You must
order
give
on
me an
you.
opportunity to respond to you.
You already
You
responded. I
told
didn't
me that
take
the member,
anyone's time.
Member Bakufos, you're
Chairperson.
out of order.
I didn't
No,
take
member, you are
anyone's
out of
time.
order.
I'm not.
You
The question
spoke,
was not answered. I posed a question.
Member Bakufos.
The question was supposed to
Member
be answered.
Bakufos.
And you, as the chairperson, you were supposed to say you did not answer a question, but I'm not the chairperson.
No, member, you are very much wrong. You are very wrong.
How?
You are, I'm not your keeper, member. You're supposed
You
to keep
are the
tab.
chairperson.
No,
You
but
cannot
you're
say,
supposed
I
to
don't want,
keep
I don't
tabs
want
on
you to be
whether
my keeper.
the department
I don't want a
responded to
keeper.
you. Remember,
I
I'm
don't
not going
want
to
a
entertain
keeper.
this. That's where I
Chairperson,
conclude.
I don't want a
Do you
keeper.
have any resolutions, Member Van Vogel?
I don't want a keeper chairperson. I want a chairperson that will be fair to both organizations,
Member Van
the
Vogel, will you
members
please proceed
and
with your
the
resolutions?
and the department. No, don't do that.
Thank you, Chair. Chair, I think our problem is when we start meetings and agreeing on on a certain time period. Meetings like we just have, I think we need more time, or we need to agree beforehand. 2 hours is not going to be enough. If it happens, then we will take a extra 20 minutes. But that needs to be before we start the meeting. Because I still have some questions. I'm not really clear, but because of time is always a problem. That's why we call these guys here so that they can explain and make things clear for us. So I really want us to look at that. But in a way, it's also our fault because we were not supposed to agree with you when you put 1 hour per presentation. Nevertheless, Chair, mine is on the minister, the city. I'm not sure, was it in my term that you have the city here, but I'm not aware that the city was here during my term. I want really, because the reason why we are focusing on the city is because there was threats that they are going to close down cities. That's the issue. So now they mentioned about the other 9, and if you go through the presentation, and as mentioned by the minister and the team, the other 9, they are not sure what the city is going to do, but we are pouring money into the city. So for me, they need to come and explain what is their plans moving forward, because we are giving them money. So my recommendation, therefore, is that we need them to come and account in terms of their way forward if it comes to the other 9 clinics. Thank you, Chair.
And then there was also the one on the staff. I think it was at the benefits. Yeah, Dr. Karim didn't have the information to his disposal. Member Van Vogel raised the question in terms of the staff. No. I think that resolution, member, in terms of it said that
That I think that was answered. That was answered, but now the clarity that I was seeking from the chair is to ask. You said that the city must come and brief the committee. Brief on what? Because yeah, on close proximity. Okay. Okay.
it wasn't answered, yeah.
That was like the city kept their staff. They
Deployed
answered
them.
that, but not what the vacancy
Mm.
in the department now with the taking over of those 10 clinics. Yeah.
You have that, Namonde? No, not
That was the staff complement, including vacancy rate and breakdown per occupation. That's the information that they will send to us.
that they did not have.
Over
with them,
recommendation, yeah.
Member Barnes?
On a question that I've asked about Philippi, where the residents are serviced, I didn't want to have a back and forth then. I thought maybe let me put it as a resolution. If maybe the department can give us the clinics that are servicing the Philippi area. If I just want to see that.
Okay.
It would help me in moving forward. I don't want to back and forward without having something on paper, if we can get that.
Sure. Thanks, Member Barnes. Member Fry?
But I got nothing at this stage.
You covered. Thank you very much.
Then the last one, Chair.
Go for it, member. Mm-hmm.
Now, I'm checking the wellness issue, ne? Is it possible for the department to provide us with stats on addressing the nurse, the wellness of their staff? I'm not sure. I want to check, because we are getting the complaints, nurses saying the department doesn't care about them. They are going through
Specifically to nurses or employee wellness in general?
I think let's make it in general so that it's all of them are covered
What
under.
did you want to know with what programs they offer?
Yes, what and how many up until now, and how many to take part in those.
How does it get phased in and
Yes.
so forth? But employment, I think first we should ask what employee wellness programs the department offer and how, yeah, and the participation of staff. Is that what we want to know? I think that concludes, members. Members, then we're supposed to have a briefing by the research unit on the TB, on their research document that was provided to us. Are they ready for us? Are they online? Okay. Who's online? Still? Oh, okay. You are excused, Member Fry. Thank you so much. Have a wonderful weekend. Yes. Is it Mr. Babu or Ms. Del Carme online? Welcome to our meeting.
Thank you very much, Chairperson. I'm not sure if Mr. Babu is online at the moment. My senior is online. Her name is Amaran. So she is online. She can just do a quick introduction to the research unit, and then I will do the presentation.
Good
You may
morning.
proceed.
Good afternoon, honorable members. This is Amran Namdu here. I'm the senior officer for the research unit. Thanks for having us today. Lisa Dalkami, our researcher that I'm sure you are all familiar with, will just briefly take you through the presentation, and then we'll also just have a short opportunity for questions. Our manager has another meeting, but he might join us in between the sessions. So in the interest of time, we will just proceed. I hope that you find this in order.
Thank you very much. Do you mind flagging the presentation online as well? Thank you.
Okay, could I just request from the honorable members if they can see the presentation?
We can see. Thank you.
Okay, thank you very much, Chairperson. So before I actually go into the presentation, I'd just like to remind members just of the scope of the research, because I know it was conducted early in April. So just to familiarize yourself again. So initially, the scope of the research was to take a look at Northwest, and given that they had established a TB caucus, you wanted us to also see if they have a terms of reference. But given in the time period and the fact that we didn't receive any response from them, we then alternatively had a look at the Global TB Caucus and had a look and see whether they provided any guidelines. And then we also looked at the example of the SA TB Caucus to see how they established their caucus and then the scope of the work that their caucus were provided with. Okay, so I'll just move on to the next slide. So in terms of the presentation outline, the presentation will cover just a brief overview of the Global TB Caucus. It will provide the guidelines for establishing a TB caucus that was provided by the Global TB Caucus, and then looking at the establishment of the South African TB caucus as well as the scope of their work. And then we'll just look at briefly what options there are for a parliamentary procedure for establishment of a caucus or ad hoc committee in the Western Cape, and then I will provide some concluding remarks. No problem, Chairperson. So in terms of the Global TB Caucus, it was established in October 2014 to accelerate progress towards combating the spread of TB epidemic. The Global TB Caucus consists of around 57 national TB caucuses worldwide, with over 2,500 parliamentarians from more than 150 countries. Included in this is the South African TB Caucus, which was launched in 2018. A big importance has been placed on both national and provincial caucuses as well, because they feel they perform a critical role in the fight against combating TB by leading programs and interventions in each domestic context, and also holding governments accountable to ensure that commitments related to TB are in fact delivered. The Global TB Caucus does provide very generic guidelines. So it's not really a step-by-step guideline, but they do provide some guidelines in terms of when you are establishing the TB caucus, you should take certain things into consideration. The first one is that membership of a TB caucus must be open to any parliamentarian from any political party, that no political representative can be excluded from membership of the caucus and participation in its activities. The TB caucus does not have the authority of Parliament and is not an official parliamentary body. So in this case, it's not regarded as a normal committee, a parliamentary committee. It would be seen as a very like a informal type of body. So in order to establish a national or provincial TB caucus, the following two documents would be required. This is the terms of reference, and this is to ensure that parliamentarian is clear on how the caucus operates and the role of the members, and then also the founding document, which articulates the caucus's priorities as well as the principles of members that they need to adhere to. And members will also see within the report, it is in the, I think it's the annexure or the appendix part, they do give the example or just some guidelines into what should or could be included in both the terms of reference as well as the founding document. And then They do provide guidelines in terms of the host, or in terms of hosting its first meeting. So it's like the launch meeting. And they do indicate that you need to ensure that civil society is represented at the meeting. Members should also have a debate or a discussion on TB in the country or in the province, and also highlight the role of parliamentarians in addressing TB. The respective officers, such as chairs and presidents, should also be elected to lead the caucus at this meeting. And then following the election of the officers of national caucuses may also appoint a secretariat that will support the work of the caucus. And then lastly, in terms of registration, so normally what happens at the meeting is that the founding document is agreed to and then signed by the elected members. And thereafter, the Global TB Caucus will need to be notified once the TB Caucus is actually successfully launched. So just looking at an example in terms of the SATB caucus, it's also not very much as a step-by-step way or guideline in terms of how you could possibly establish a caucus, but it does provide, various resolutions they made when they were establishing the caucus. So we know that the SATB caucus was established by means of a resolution by both houses of parliament at a plenary sitting. And then at the launch, it was led by the speaker, and there was a debate in both houses on the state of TB in SA. And then they resolved at the sitting that the chairperson of the Portfolio Committee on Health and the chairperson of the Social Services Select Committee would act as co-chairs of the SATB caucus. Just an important establishment as well was the coordinating body, which is also seen as a joint committee because it does consist of members of the NA as well as the NCOP, and this coordinating body would assist the caucus throughout its work. So also coordinating its work, identifying maybe things that they need to monitor or programs or workshops they should have, so they do provide some form of guidance. Just looking at the scope of the work. So the Global TB Caucus does provide, obviously, the role the TB Caucus would play. But in terms of the scope of the work, that is obviously identified by each specific province, whether it's a national, whether it's provincial level. The scope of the work would need to be determined on that level. So in terms of the South African caucus, they are allowed to advocate for the necessary resources to accelerate progress to NTB, to also monitor the kind of spending on TB programs, review legislation that inhibits access to TB services, or passing legislation that promotes the access to TB services, and then review health indicators, and then also possibly perform site visit to inspect the performance of specific TB programs, and then calling public institutions into account as well. And then lastly, raising awareness of TB by engaging with both the media and constituencies on TB. So just taking one step back before we do conclude on the presentation, we also thought it's important to maybe just look at the Western Cape and what structures they currently have in place. So the Global TB Caucus does advise that when you do establish a TB caucus, is to determine whether there is a recognized way of setting up an informal parliamentary group within the province. So in terms of the Western Cape, there's no standing rules that outline a procedure for, establishment of a caucus, although there are standing rules that outline various ways an ad hoc committee can be established. And which can possibly be referred to when establishing the caucus. So, which is similar to the South African example, the SA caucus, it was established by resolution. So with the ad hoc committee, it also can be established by a resolution of the House. And in this case, it will be introduced to the House, it will be reviewed, debated, and then they will vote and adopt the resolution. Or in a case of being established by the speaker, this normally takes place when the speaker or when the ad hoc they will consult with the whips in the circumstance where the house is maybe adjourned for more than 14 days. So the speaker then can consult with the whips and then decide to establish this ad hoc committee. So this is just thought I'd give some info in terms of what procedures are currently available or in place in the standing rules that the committee can consider. And then just some concluding remarks, just to sum up the presentation. So the Global TB Caucus was established to accelerate progress towards combating the spread of the TB epidemic, and there were targeted actions both at global, regional, national, and provincial levels. The Global TB Caucus does provide various genetic guidelines to assist parliaments and legislatures, but the key important part is that the TB Caucus is non-partisan, so meaning that it's open to all political parties as well, and that there needs to be a terms of reference and a founding document. Although each TB Caucus is united by their shared commitment to end the TB epidemic, the scope of its work should be determined by the severity of the disease in the country or the province, the health objectives and the plans of the country or the province, and then also looking at available resources in times where they might need support or funding to actually support the work of the caucus. I think at this time it's also important to note that the best way to actually investigate or to find out, what's the best way to approaching this, to establishing the caucus, or to look at other guidelines is to possibly visit other legislatures or visit other countries and to engage with them as well to identify what they actually did or what steps they took, and also to refer to maybe their terms of reference as well. But Chairperson and honorable members, I thank you so much for your time and for allowing us to present on the report.
Thank you very much, ma'am. Yes. Any questions, members?
Thank you, Chair. Just a quick one on the presentation. I think from the first slide, it was speaking on identifying one or more parliamentarians who have interest in TB. What I want to know, it doesn't say clear, it says one or more. What would be the number for parliamentarians that would be serving on this TB caucus? And then the second one is on the registration part, the bullet point that says caucus may need to be registered. What I want to know in a case of us being members, what is meant by registering? Who are we registering with? Or how is the registration process seem to be done? If we can get an explanation on how do we legitimize this. Thank you, Chair.
Thank you, Member Barnes. Is it this Ms. Delkami? Yes. Ma'am, is this a question, Member Barnes's questions, is it directed to you or would it be Mr. Daza? I know you.
No problem, Chairperson. I'm sure. I think I might have to get Ben to come in or Mr. Daza to come in, because it's not clear on, first of all, the number of members or if there is a quota in terms of it can only have a certain number of members. So I would like if Mr. Daza could come in. Thank you.
Thank you very much, ma'am. Mr. Daza.
Yeah, thanks, Chairperson. I think from our side, we would advise that this issue be referred to the Speaker's office because only he can determine that part, because we do not have a procedure in Parliament as it stands. I think it was indicated in their presentation as well. So our only option, my only advice to the committee is to request them. I think the committee has done that already, but I don't know what is how do we proceed from that? Because we haven't had a response, because the committee did request from the Speaker's office what would be the procedure since our rules don't speak
provision
to that part. Yeah.
Thank you very much, Mr. Daza. I think for myself to ascertain, and I think for other members as well, in terms of the global phenomena, in terms of TB in the Western Cape, we can certainly see the need for such a body. So a caucus cannot be established in terms of our rules, but the ad hoc committee can be called into life, if I can call it like that. Now, Mr. Daza, I need to understand from, we've done, the research was done, we've requested the research, we've seen the research. For us as a committee, what is our step further in calling or launching this ad hoc committee at the end of August?
I don't know about the timing, Chairperson, but I would advise the committee to take a resolution to say, as the Standing Committee on Health, this is what they advise should happen. You can maybe write a report to the Speaker, to the House, to request that an ad hoc committee be established. Because
okay, we've had that conversation.
Yes, because in terms of our rules, only the House can establish an ad hoc committee. But in terms of a caucus for the province, still the Speaker's office must advise us on.
I think we've determined that already, that
yes.
the rules doesn't make provision for caucus, so it will have to be an ad hoc committee.
Yes.
So next thing would be that a motion be tabled in that regard.
First, we need a committee resolution, yes, to say that the committee resolves that an ad hoc committee be established, but that must be approved by the House. Only the House and the Speaker can establish an ad hoc committee in terms of our rules. So this committee must resolve on requesting that an ad hoc committee be established.
Member Van Vogel, I see you have a question.
Yes, there must be a committee decision first, then for it to be considered by the House or the Speaker, because according to our rules, only the House or the Speaker can establish an ad hoc committee. But first, the committee must resolve here that process must kickstart. Then it will be up to the Speaker's office and the President.
Ms. Jamke must just help me. I think we have a previous resolution, but I think one can add on to that we had the briefing by the research department based on the research document as well, and just add that too. And since we do not have all members present at this point, perhaps by round robin, just present the resolution and ask members for their concurrence thereof during the course of today. Will that be in order? Is that fine with you, Member Van Vogel? Yeah. Yes, we have not concluded on that. I've actually written a note to Ms. Jamke earlier on for us to have an engagement with the Speaker and the Chief Whip with regards to that. So let us furnish the resolution today and try to have that meeting on Monday. Is that in order, Member Van Vogel? Yes. Are you out of town? Online? Not? Okay. But let's see what accommodates your diary in order for us to get that done. Are there any other committee business, Ms. Jamke? No. Nothing? Thank you very much for your support and all of your wonderful hard work. Mr. Daza, thank you.
Thank you.
You only came for 5 minutes, but we say thank you. Thank you very much to the research department online for your indulgence of the committee today as well. Thank you to all our support staff. This meeting is now adjourned. Have a wonderful weekend, everyone, and be safe. So, twee uur weer vergadering. 2 uur. 4 uur.